Good morning, all. I'm Dr. Arya.
I'm Dr. Vrinda. A warm welcome to all the delegates gathered here. We are extremely happy and equally excited to welcome you all for the unique CME YOLK Insight organized by the youth of Kollam under the guidance of veteran KOA leaders.
The sessions will be an omnibus of a variety of topics ranging from hardcore ophthalmology to beyond ophthalmology. We have a set of young and vibrant speakers joining us today. Also, don't forget about the quiz session for residents where we will have loads of fun.
So with all the blessings from our seniors, we will start the session. In total, we have 4 sessions with 4 to 5 topics per session. Each talk will be for 6 to 7 minutes and will be open for the discussion at the end of each session. Once again, we welcome you all to the YOLK Insight CME. Let's begin.
So during residency, we all have doubts regarding how to prepare for exams, thesis work, where to collect resources, get into subspecialties, so and so. Our first session, which targets the residents and fellowship aspirants, deals with maximizing the residency outcome.
Let me invite the panel for the session. The chairperson, Dr. V. Sahasranamam Sir, retired professor and HOD, Government Medical College, Trivandrum, and director of RIO. Currently, director and senior consultant at Chaitanya Eye Hospital, Trivandrum. He has special interest in pediatric ophthalmology. Hearty welcome, sir.
Let me welcome the co-chairman for the session, Dr. Smita Narayanan. She is Professor RIO Trivandrum. She has special interest in glaucoma and research methodology. She is the editor KJO and assistant editor IJO. Hearty welcome, ma'am.
Next, we have the moderator for the session, Dr. Dhanya RS, assistant professor TDMC Alapura. She has completed her vitreoretinal fellowship from Aravind Eye Hospital, Tirunelveli. We welcome you, ma'am. Now let me hand over the session to Dr. V. Sahasranamam, sir.
So good morning. Yes.
Dr. Chaitanya. She has completed her MS Ophthalmology from RIO Trivandrum. She has a fellowship in Pediatric Ophthalmology and Adult Strabismus from Aravind Eye Care Center, Tirunelveli. And she was a former consultant in Chaitanya Eye Care Center. And now she's presently is working as consultant pediatric ophthalmologist at Chaitanya Eye Care Institute, Tiruvalla. So welcome Chaitanya for the first talk.
Good morning. Thank you, Kollam Ophthalmic Society, for making me part of this wonderful CME. I am going to talk regarding how to prepare for FRCS and ICO examination. There are so many international examinations in ophthalmology. But before choosing which exam or whether we to write exam or not, we should think about what is our motive for international exams. It can be for an additional degree or for increasing the length of our post-nominals or to clear new exams. Or the important thing is for job prospects or to settle abroad. Any may be your idea, but always plan according to your needs and not by looking at the peers. Always make a clear roadmap before even thinking to start the exam, because this is both expensive and time consuming. The very important questions comes when to start the exams. The sooner, the better. You can prepare by the end, for the residents, you can prepare starting to plan and prepare for the examination by the end of your first year residency of ophthalmology. And for the others, they can start preparing early. The most two common exams are FRCS and FICO. Both are comprised of 3 parts. Just to compare between FRCS and FICO, both exams are having 3 parts. For FICO, for 3 parts, it's basically MCQ exams. Part 1 and Part 2 of both FRCS and FICO is just comparable MCQ exams, and the topics are almost similar. And one advantage for FICO exams is, if you clear Part 1 and Part 2 FICO, you can directly go for Part 3 FRCS. From 2021 onwards, there is no Part 2B exam for FRCS Glasgow. So by passing FICO up to Part 2, you can go for Part 3 FRCS. Or if you are opting the other channel of FRCS only, can go for Part 1, Part 2 FRCS and for Part 3. FRCS up to Part 2 is MCQ. Part 3 is basically practical model comprised of OSCE and clinicals. FICO Part 3 is also MCQ, and it is advanced MCQ exam questions. Just to compare the Part 1 and Part 2 of Part 1 of FRCS and ICO, both MCQ questions, the topics questions will be from basic science, optics. And the model is almost same, and time duration is little more for ICO. Fee structure is also comparable. Part 2 FICO and FRCS Glasgow is also same with MCQ questions only. One advantage for ICO is there is no medicine questions in ICO exam models. After passing FICO Part 2, if you don't want to write any more exam, you are fed up with all the exams, then you can just apply for MRCS Edinburgh. You will get the post-nominal MRCS Edinburgh. Or you are more interested for exam, your goal is different, can apply for FRCS Glasgow Part 3. And the entry for FRCS Glasgow Part 3 is, you should either clear up to Part 2 FRCS or Part 2 FICO. And the seat for FRCS Glasgow is based on slot system nowadays. So it will just based on your luck for the slot. And there are, all over the world, there are 7 exam centers will be for every year for FRCS Glasgow. And another thing is, after FICO Part 2 can also appear for advanced ICO. After clearing the advanced ICO MCQ question, you will get the post-nominal FICO. Also, after passing FICO, can apply for ICO fellowships, international ICO fellowships, 3-year, 6-month and 1-year duration. After completing ICO fellowship, you have to come back to your own country and should practice. Also, there is another one advantage. After new 2021, from 2021 onwards, of the new scheme advanced ICO exams are there. After passing that, for FRCS Edinburgh Part 3, you have to appear for the Viva part only. No need for Part 1 and Part 2. FRCS eligibility is, for Part 1, you need to just complete your MBBS with 1-year internship. For Part 2 FRCS, you need 4.5 years experience in your specialty after internship. Part 3 just need FRCS Part 2 pass or the equivalent exams. Already explained, MCQ Part 1 FRCS will be from basic science and optics and refraction. Part 2 is also from clinical ophthalmology. The questions will be from medicine and neurology also. Part 3 is the most important parts of FRCS. It's basically comprised of OSCE and clinicals. OSCE, one day you will have OSCE, other day you will have clinicals. OSCE comprised of 3 stations, 20 minutes each for each in each station. For 10 minutes, first one examiner will be asking you question, and the next 10 minutes the second examiner will ask you the questions. 3 stations are anterior segment oculoplasty, posterior segment, and the third is neurophthal and motility. The questions will be basically clinical case scenarios or the pictures. They will ask you practical based questions only. Practical, next day clinicals will be basically practical. 4 stations will be there. Each station is 12 minutes each. Minimum you need to examine 2 cases. Anterior segment, posterior segment, oculoplasty, neuroophthalmology and motility are the stations.
Sorry,
Just
ma'am, we have completed 6 minutes.
Just one more minute. Tips for passing Part 3 is, you should be very practical, methodological, plan and prepared answers are they are expecting. And should always you need an insight into the exam structure. Study strategy should be maintained. Communication skill is very important. Time management is another very important. And seek help from a mentor. And always strive to be a better clinician. Just to compare between FICO and FRCS, FICO is just for the post-nominal and for fellowship. FRCS for practicing at abroad, and for GMC registration, FRCS is very important. Just to sum up, you have to have a balance between your study and work during your exam preparation, and always acquire maximum clinical skills from your OPD during your residency. Stay positive, work hard, you can make it happen. Thank you.
Thank you, Dr. Chaitanya. Would you recommend some books or some websites for your FRCS or FICO?
So many websites are there. In initial parts itself, you can enroll in Muthuswamy Virtual University. They will send you questions. You have to send the prepared answers to them back. And the CHUA website is there. Their past candidate experience are there. The recent past candidate experience will give you the model of exams, and also based on that questions, you can practice by yourselves how to answer the questions. Time management will also be very useful. So many online courses are also conducting, like no financial interest, like Moonlight Academy, e-learners academy, extra. So many online resources are also there. Also for books, CHUA books and Cakewalk, extra, so many books are also there.
Thank you, Dr. Chaitanya. So the next talk we will have about solving exams.
That was a nice talk, Dr. Chaitanya. Now, a few things, few information. One is FRCS Edinburgh has been stopped for the time being. For the last 1.5 years, it is not there. It's only FRCS Glasgow. That's the only one available. And of course, as she rightly said, if you write FICO, part 1, part 2, then part 1 and part 2, you can go straight to FRCS part 3. Only thing is, if you want to take MRCS, then you have to write MRCS part 2. That is one thing. Part 2 has to be written if you want to get MRCS. Okay? It is changed, and it is true. Yeah. And another thing is, there is no time limit when you can write FICO or FRCS and all. Because when you are young, when I started my post-MS practice, I was getting 1,800 rupees per month. So it was not easy to go ahead and write this exam, because it was too much. If you fail, that fear is there, 50% chance you may not get through. Then that fear is always there. So as you go along, when you have adequate money, go for it. Or if you have an option, or if you are planning to settle abroad, definitely early. As she rightly said, early is always better. Thank you.
Thank you, sir. Thank you, sir. Okay, let me invite Dr. Rakhi for the next talk. She is a consultant phaco surgeon at Ahalya Eye Institute, Kollam. And she has also completed her medical retina fellowship from Comtrust Eye Hospital. So she'll be talking to us about solving exams, tips to face exams fearlessly. So that's a very important talk, especially for the postgraduates, I feel, and also the exam-going people. Over to you, Rakhi.
Thank you. A very happy good morning to one and all. So I'll be sharing some useful tips to the younger generation, that is the postgraduates, on how to plan, prepare, and conquer your exams. So during the first year, each one of us goes through these dilemmas. Should I buy all the books now itself? Should I start reading the reference books? Oh my God, my seniors are reading from DOS articles. Should I read the DOS articles now itself? Or should I read for gaining knowledge or for my exams? All these are questions which goes on in your head. But I would suggest that during the first year, to know about the symptomatology, standard definitions, and clinical examinations, Parsons and Kansky is more than enough. But read case-wise. Whenever you see a different case in your OPD on that day, go and read about that case that day itself, so that you will not forget about that case. And make it a habit to read every day, at least for 30 minutes, 20 minutes, or if possible 1 hour. But if you have got some commitments, like you want to go out with your friends for a movie or to have some fun, it is fine. Never miss an opportunity to have fun also. but try to compensate for that time in your upcoming days. Stay focused and organized. Start preparing notes. So, during the initial period itself, make separate books for each topic. For example, this is a note of Dr. Harini. She is a gold medalist. And she has got separate book for each topic. See, this is a retina book. In the first page, she has written out the contents of that book. And this is her notes on CRAO. She has highlighted the main points. But when she reads something from some other article or gains a little more knowledge, she writes it into a sticky note and attaches it to the same note. And if she reads something from any other articles, she'll take a photocopy and stick onto the same book so that by the end of the final year, you will not forget from where you have read it. So it will be easy for you. Sometimes for some topics like LATES, dry eye, etc., Kansky will not be enough. So in such cases, you have to go and read the reference books also, which is available at ilearn.com. And once you become the exam-going PG, you become the center of attraction of everyone. So then, start increasing your study hours per day. Refresh your refraction and basic sciences once again. Start preparing for case presentation. Create your own question bank. And when the most awaited period, that is the study holidays, comes, mind you, study holidays are basically for revision. But you can keep the volatile topics like the optics, diagnostic, etc. towards the end. When you start writing your theory paper, be crisp and keep a format. This is a format which is commonly being followed for clinical questions and investigations. I'll share it with you. Be legible. Try to write in a good handwriting. But if you don't have a good handwriting, just leave enough space in between so that it will look neat. Use a maximum of 3 colors for highlighting. Use 1 or 2 flowcharts to make your paper look attractive. Draw big diagrams. Leave space above and below. But label only on one side so that it will look neat. By the time you reach your final year, you must have already lost the art of writing for long hours. So practice writing paper for 3 hours. You can do it with the mock test or self-testing with all question papers. Practice time management, that is a must, or else you will come out crying out of this exam hall. If you don't have much theory classes at your institute, no worries. There are a lot of major institutions which are giving online classes. For example, this is a YouTube site of RP Center IIMS. They already give out a timetable of what all classes they are going to take and what time. Even they have classes on instruments which tells about the designing features and uses, which is usually not taken at any institute. Shankara Eye Foundation again has its classes on recent advances and diagnostics, which again is usually not covered. LVP also has a set of classes which will be very useful for the postgraduates. One of my favorite is this practical exam-oriented classes, which is called the problem-based learning, and UNI classes, which are actually interview-type classes, which is very helpful for your Viva-Voski. And attention retention modules are small 3-minute to 5-minute modules, which you can watch anytime. And once you come to the dreaded practicals, be calm, composed, and confident. Mind you, confidence again comes only by examining patients, so never miss your clinics. You should have your case pro forma by heart, and while answering, be audible and to the point. Practice, 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 because practice makes one perfect. These are my suggestions of the books to read for practicals. I'll share it with you. And for practicals, again, there is this site by iFocus, which is run by Center for Sight, which have many OSCE modules, classes on microbiology, pathology, and even refraction classes by legends like Dr. Krishna Prasad. And then we have this small study group, which is called the Spotify study group, which actually discuss on images, OBSCAN images, Pentacam images. If your institute doesn't have these images, go to this site, and then you can learn how to describe also. There it is written how to describe also to the examiner. So these sites are very, very useful for all the postgraduates. So most of my contents here are taken from Dr. Pranesh Balasubramanian's talk with Dr. Harini and Sanira, and my acknowledgement to Dr. Pradeep Gupta and Saurav Deshmukh also. Thanks a lot.
Thank you, Rakhi. That was really, really practical and very wonderful topic. But a few of my PGs say they have a blackout a few days before the exam. They don't remember anything. Can you give us some tips for how they should go about?
So even if it is for theory or for practical, nerves are there for everybody. Nerves are supposed to be nervous. So everybody will be nervous at the initial period for writing exam or for practicals. But my suggestion is relax, take a deep breath, keep taking deep breaths for 1 minute. You'll be fine within few seconds and every blackout will clear out.
She was saying you practice yoga, right? Meditation. No, I didn't mean it as a joke. So because nowadays, no, everybody is pressed from LKG onwards. Then the newer generation PGs who are sitting here, no, from the LKG onwards, we didn't have, even for the MBBS admission, we didn't have too much of pressure. So you learn to be relaxed. So that means you try to keep your mind under your custody. And another thing you said for the first years, you read Kansky and Parson. So they will read Kansky and Parson for sure. But I have always found that unless they read the basics, anatomy and physiology, the ideal books. So unless you read it in the first year, you are not going to read it all. So you will tell everything about OCT, you will everything about Okta, you will say everything about topography, but once asked basics about the retina, cornea or uvea, no, you will not know. So first years, because when we were PGs, no, in the first year we had an exam on the basic sciences. I think it's very, very important. Unless you read the basics, no, so we always say the foundation should be good, no.
Yes.
So once you reach one stage, you know how the foundation is important. Otherwise, no, you won't know. So you at one point of time, when you are slightly wobbling, you are unstable, you know that your foundation. So it's not the time to recognize that your foundation is not strong. The foundation should be strong from the year one. So that's something which I would like to add to that. And be calm and composed. So if you prepare in the way she told, no, you can face the exam, and with a bit of composed nature, you can face the exams comfortably. Yes.
Thank you, sir.
Thank you.
Now, I got a few tips. Were you actually calm and composed when you wrote the exam? Right. No, see, to be calm and composed, you should have a very good knowledge. Otherwise, you won't have confidence. If you have confidence, you will be calm and composed. And how to prepare yourself to be calm and composed, you have to learn. And don't think it is a science like mathematics, 2 + 2 is 4. You have to mug up. There's no doubt about it. Now, you should not feel the demeaning like you have to mug up. It's not like that, you have to mug up. There's no doubt about it. And about writing these notes, what I did was I didn't have these separate books, notes like that. You will lose them. There will be some 50 books you will have ultimately. You don't know what to look for where. What I did was I studied all these standard textbooks, right? Parson, then Stallard. We didn't have even Kansky at that time. And what I did was I wrote the extra points in the margin. All the points are there, it is there in the book. You don't have to have more notes about that. You can't have. But some extra points you can write down. You can, from journals, you'll get some extra points about laser. So there will be a chapter on laser in the book, so you write there. So that you won't lose. Chapter-wise and page-wise, it will be there. It will be easy to search when you go for the exam. Diagrams you have to learn, draw, learn. Otherwise, you cannot reproduce that in the answer book. And as Sasraman said, anatomy is the mainstay of going forward. In surgery, in practice, we had our professor Matthew Rice are telling a patient comes with organophosphorus poisoning. What is the treatment? Atropine, and atropine. We have given 200 vials of atropine on a patient. Like that, anatomy. There's no other go. And I know, of course, many PGs know I draw these diagrams on the board, bony orbit, marking the important events there, the attachments. You have to learn by drawing and practicing. Okay.
Sir, thank you so much for the points. And just 2 points I want to make regarding the very important points that Rakhi made. First is about the notes. I will not say how I made notes because that era is gone. So nowadays, what I tell my PGs to do is to make e-notes. It is very, very easy to add on your notes if you have correct folders for retina, cornea, conjunctiva, everything. Just like she said, but it can be on the system. And it's a very nice way of keeping on editing and adding, and there is no problem of, nothing. I mean, that is what I generally advise the PGs, and I don't need to do that because they are already, they are more savvy about all these things right now. It's only the attitude that is sometimes lacking. So that's one thing. And the second one, oh God, oh my God. More than that, I enjoy this. Forget about the head of the department, but I really enjoy both learning and teaching. So that's why I thought I should contribute to this. And the second thing that I wanted to make the point was about the blackouts. Yes, the blackouts and the thought blocks are very, very common. Even yesterday I was conducting a dope session for the undergraduate. I was asking him to demonstrate the Hirschberg test, thinking that that's the easiest thing I could help for him. But he demonstrated the pupil reconstruction using the torchlight. So that was a complete thought block. So thought blocks do happen, and it is not a big problem now because as teachers, we are in a very student-friendly environment. So as teachers, I think we understand when the student is having a thought block, and we try to help. And as for students, I think these days students are very much welcome to say that, can I take a deep breath? Can I have 2 minutes? I will be back. I'm having it. Nothing wrong in that. Please feel free to say that during your exam. In a nice way, of course.
Thank you, madam. That was very valuable information from our dear teachers. So I want all PGs to listen to that. Okay. So then next talk we'll have about the online resources for residents by Dr. John Davis Akkara. He's a glaucoma, cataract and refractive surgeon in the Western Eye Hospital and Chaitanya Eye Hospital, Kochi. And you all know him. He's a very tech-savvy person, and we'll have a brilliant talk from him. Over to you, sir.
Thank you, ma'am. Thank you to the Kollam Ophthalmic Association for this wonderful, informative CME program. And to all the PGs, now that this is the digital age, what ma'am said is very, very useful. You know how to do it. You just need somebody to tell you to do it. Okay, so make all your notes digitally. And this is about all the digital resources which you have. And also, you have to know that all of you may not learn the same way. Some of you will be visual learners. Some of you may learn better from PowerPoint presentations. Some might learn better from videos, YouTube videos. Some might learn better from reading the book and writing your own notes. Some may learn better from listening to podcasts. So find your best way of learning and do that. Okay. So this is a long presentation because there are so many online resources. Not all of it is for everybody. Find the ones which are useful for you. So a lot of innovations in technology. We have lots of free, affordable, and sometimes completely free resources which help you learn at your own pace in your own way. You can multitask. So while you are driving, you can listen to podcasts. You can, you might be doing something else, cooking or something, and you might watch a YouTube video in the same time. So multitask, because that is the time now. Lots of types of resources. There are several websites, Facebook, Instagram pages, WhatsApp, Telegram groups, YouTube, iTunes videos, webinars, podcasts, ebooks. So many things are there. Find the ones which are useful for you. This particular article in Kerala Journal of Ophthalmology, I have listed quite a few. So just note this if you miss some parts of the talk. And I think it's on YouTube as well, this talk. And also there is another ebook again from Dr. Pranesh Balasubramaniam and Dr. Subhashni Manoharan. They have also compiled a list of online resources. And the AIOS Proceedings website has all the recorded talks of the previous few years. There are PG update programs there, which is the main thing which you will want. The other talks, you might find it interesting. If you have time, look at that. But PG update programs on the AIOS Proceedings website, very useful. iWiki website, you can go and study particular topics there, and you can also make an account there add your information, add a new article on some other new topic which you learned, and you will get a prize if it is the best article for that session. Okay, every year you get a best article prize for international ophthalmologists, and if you get that, you can apply for the International Hero Award for All India Ophthalmic Conference. Okay, pro tip. And if you want to learn more about cataract surgery, cataractcoach.com is a website which is very useful. eOphta is a very useful website for all ophthalmologists. I hope many of you have already visited this. And there are several PowerPoint presentations as well as articles available. I learned, again, Dr. Saurabh Deshmukh and Krati Gupta, they have created a big database of previous question banks, PowerPoint presentations, interviews with toppers, interviews with fellows, so that you can have a good idea. That is, I learned. Orbis Cybersite has learning resources as well as webinars which you can attend. Some of them might be above your level, but just find out the ones which are for your level and go to those. Root Atlas by Tim Root. Ophthalmology is full of pictures, so you have to look at pictures. This is one of the atlases which you can use. And Spotify study group, again, pictures of all these investigations. You may not have all these investigations with you, doesn't matter. You just see the pictures and see the discussions and discuss whatever will come for your exam. Okay. And then the Moran Health Center, the core website is there. So they also have learning resources. Retina Image Bank, again for retina pictures. Some of these pictures, they might look different in Indian eyes, so look for that as well. And you can contribute to the Retina Image Bank, okay. iDocs is another website with lots of learning resources. And I think Dr. Chaitanya mentioned about the Muthuswamy Virtual University. They have lots of questions and you can join that as an college, and they will send you questions, you can answer them. iToday is another website which has learning resources as well as conference information and journals. Ophthalmo Bytes, they have a website as well as Instagram page started by a postgraduate, and you just follow the Instagram page, you get updates about all these retina and other findings. Atlas of Gonioscopy. I'm going to go much faster now, but these are all available in the article as well. Okay, Atlas of Gonioscopy for gonioscopy. Professor Chua also was mentioned. This is the Utah retinoscopy without a patient, without a retinoscope. If you don't have a retinoscope, doesn't matter. Strabismus simulator, again, everything is virtual now. Practice this, and then you practice on patients also. Squint Master for again squint. Instagram pages. This bunch of Instagram pages, 1, 2. Yeah, pictures. Everybody just look at this, pictures. These are all Instagram channels which you can just follow and learn while you're relaxing. WhatsApp and Telegram, Eye Surgeries Worldwide group is there. And Telegram also, you can get all the ebooks which you want. Soft copies of any ebook you want. Go to Telegram and search, you will get it. Okay. Podcasts, if you're driving or working out and want to listen. Ophthalmology Off the Grid. Straight from the cutter's mouth, Retina channel. You will learn a few things, like Shankar Netraya has snippets. For PGs, this is useful. Eyes for Ears is also useful. Then these are for articles, so doesn't matter. Smartphone apps, anatomy apps are there. Cataract surgery app is there. And other question banks and channels. So that is all. Thank you all. I think this is other YouTube channels. I'm not going to YouTube channels, but there are several. Okay. I'm just going through the page so that you can look at it later. Thank you.
So thank you, Dr. John Davis Zakaria. Actually, he is an asset not only to KSOS, to the ophthalmology as such. And any doubts you have, call him. Anytime he will pick up the phone if he is available.
You can send me a message.
A message. Okay. Okay. Because what I do is I call him because probably being a senior, I got the liberty to call. So don't call, send him a message. Right? So that is one thing. And other thing, and now the PGs of today are blessed with all this. So it's too much in plenty. So plenty, too much of plenty is also not good, but unfortunately, fortunately, you have plenty. And one thing is, all these things are there, you go through it as time permits, see cases. So your clinical acumen, it's not going to improve by this. So you see cases, say this, and so that helps to install that a case or a problem case you saw today. You go through all this, you get reinforced. So seeing cases and getting good clinical acumen, it's very, very important, though you have all these things in plenty. Yes.
Dr. John, is Sci-Hub still available?
Sci-Hub is still available. You can use the Telegram bot for Sci-Hub, which will find the active link and send you the articles. Sci-Hub.se is still available right now, but it keeps TW is gone.
Okay.
It's not legal actually. So.
Sure, that was a very informative talk. So we are running short of time. We'll go to the next talk, that is Insight into Subspecialty Fellowships after PG, and we have Dr. Jofi Phillips Cherry for the talk. Sir is presently working as consultant ophthalmologist and in the MOAC Medical College, Kolancheri. Over to you, sir.
Good morning and thank you for the opportunity. Most of us are at crossroads about pursuing a subspecialty fellowship right after post-graduation. Some of the reputed fellowships from well-known institutions are as follows and in no particular order. The L.V. Prasad Eye Institute offers fellowships in the following subspecialties. The duration is of 36 months and the eligibility is postgraduate diploma or degree. The selection is based on a 3-step process which consists of an online exam. Step 2 consists of an executive panel interview and step 3 of an online faculty interview. However, before that you have a mock drill with a webinar and an online exam just before the actual exam. The first 9 months consists of an advanced induction module, a basic subspecialty mentor-based training, and an intensive exit competency-based training programs in the first 9 months, together with comprehensive cataract surgery training. The next 12 months consists of a posting in a secondary center, and the final 15 months consists of advanced subspecialty training. The aims of most of the fellowships and a well-rounded fellowship consists of medical and surgical management of retinal of eye conditions, with special exposure to surgeries and a strong focus on research component. Shankara Nethralaya is a non-profit charitable eye hospital located in Chennai. They have an intake of twice a year, January and July. The duration of each of the fellowships may be of 1.5 years or 2 years, and the eligibility is usually is a postgraduate degree or a diploma in some specialties. The upper age limit is 40 years, and they have 2 locations in Chennai and Kolkata. Selection is based on a competitive exam, MCQ-based exam, and a viva or an interview with it. These are the fellowships offered by Shankara Nethralaya. The starting date is 1st January and 1st July. Narayana Nethralaya is another tertiary care super specialty ophthalmic institution located in Bangalore. They have a twice yearly intake. The duration of each of the fellowships are 2 years. The eligibility is MS, postgraduate degree or diploma. Narayana Nethralaya also offers fellowships in conjunction with the Rajiv Gandhi University of Health Sciences. So basically at the end of the fellowship, there's an exit examination and you get a university affiliated fellowship degree. The upper age limit may vary, it may be 35 or 40 years. The location is in Bangalore and the selection is based on a CV and viva or an interview after the CV assessment. So you don't have an MCQ examination here. The fellowships are as follows. The Christian Medical College Vellore is a Christian minority institution founded in the 1900s. They have started recently fellowships and the eligibility is a postgraduate degree only, MS or a DNB. The duration of each of the fellowships is 2 years, and this selection is based on a competitive MCQ-based examination and an interview following that. The number of seats in each of the subspecialty fellowships are one. Special note is the community and comprehensive ophthalmology in this. Shankara Eye Hospitals, founded in 1977, they have a total network of 13 hospitals all over India. They have a twice yearly intake in December and June. The eligibility is again a postgraduate degree, MS or a DNB or MD, and a diploma in ophthalmology for some subspecialties. The selection is based on an MCQ exam and an interview, and the duration of each of the subspecialty fellowships may be 1.5 years or 2 years duration. These are the fellowships offered by Shankara Eye Hospitals. The age limit is 35 years. The selection process is based on applications and 2 letters of recommendations. Arvind Eye Care System consists of a network of 16 plus hospitals, and most of the hospitals are located in the state of Tamil Nadu. And outside the state, they have in Tirupati and also in Pondicherry. The eligibility is a postgraduate degree and diploma. The duration of each of the subspecialty fellowships may be 1 year, 1.5 years, or 2 years. The selection here again is based on an MCQ exam and an interview. The upper age limit is 36 years. These are the fellowships offered by Arvind Eye Hospitals. Coming to fellowships in Kerala, just some of the institutions providing fellowships are Giridhar Eye Institute. They have a long-term fellowship of 18 months or 24 months depending on the subspecialty. Little Flower Eye Hospital and Research Center Angamali also offers long-term fellowships. Comtrust Charitable Trust Eye Hospital located in Calicut also offer long-term fellowships in glaucoma, medical and surgical retina, and pediatric ophthalmology. Chaitanya Eye Hospital and Research Institute Trivandrum also offer long-term fellowships in vitreoretina, glaucoma, medical retina, pediatric ophthalmology, and comprehensive ophthalmology, and the duration may vary between 1.5 years or 2 years. Kindly feel free to send in your queries to my email address. Thank you for your patient listening, and I would like to thank the organizers for giving me this opportunity.
Thank you, Dr. Cherry. That was a very comprehensive presentation. I think JIPMER has also started a fellowship program for 1 year. So that would be also beneficial to the PGs because it's only for 1 year.
Yes.
That is only after senior residency.
After senior residency. So most of the PGs would be finishing senior residency, isn't it? Before for the fellowships? Is it?
They have to finish junior residency, that is PG, then have to do senior residency and then
go, yeah. What about the other fellowships?
Other fellowships directly after post-graduation.
You don't have to do senior residency. Okay, thank you.
Yeah, and I think for the postgraduates here, you have to plan ahead for your fellowships, not after completing your MS that you have to decide whether to go for it or not like that. So you should have a mindset that you will do a fellowship, you will complete your studies only after you finish your fellowships because it is a necessity and it also gives much as a person you will feel much rewarded after you complete your fellowship. Okay.
Need of the hour.
Yeah, it is exactly. It's a need of the hour.
Thank you Thank you so much. That was an enlightening session.
Now, to express our sincere gratitude to the panelists and speakers, may I request Dr. P. Rameshan sir to hand over our token of appreciation. I welcome Dr. V. Sasraman sir to please come forward. Thank you, sir. I welcome Dr. Smita Narayanan. Welcome Dr. Dhanya Aras. Welcome Dr. Rakhi Dicruz. Welcome Dr. John Davis Sakra. Welcome Dr. Chaitanya Warrior. Welcome Dr. Jofi Phillips Cherry. Thank you so much, sir.
Now moving on to the session 2. Cataract surgeries are always gratifying. It's always a pleasure and sometimes challenging to bring back vision. So we have a next session of topics on cataract pearls to sharpen our surgical skills with our adept cataract surgeons.
Let us invite the panel, the chairperson for the section. Let me welcome Dr. Jayaprasad B. He is Senior Consultant, Amardeep Eye Care Centers, Trivandrum and Kollam. His areas of interest being cataract and glaucoma. He is the first keyhole cataract surgeon in Trivandrum. Proudly welcome you, sir.
Thank you.
Next, inviting co-chairman for the session, Dr. Minu M. Mathan, consultant in cataract and refractive lens surgery services at Chaitanya Eye Hospitals, Trivandrum. He has worked at Aravind Eye Hospital and was in charge of microsurgery training programs. Hearty welcome, sir. Next co-chairman, Dr. Anu Bahulayan, the chairman and medical director of Purple Eye Hospital, Chavara. He completed the fellowship in cataract at Ahalya Eye Hospital, Palakkad. Welcome, sir.
Let me invite the moderator for the session, Dr. Shruti R., Associate Consultant in Department of Cataract and Glaucoma at Giridhar Eye Institute, Cochin. Welcome, ma'am.
Good morning, all of you. At the outset, let me welcome all of you to this wonderful session. Young people have a lot of energy, enthusiasm, and I am really thankful to Dr. Sahasranamam for acknowledging the fact that, especially to young lady ophthalmologists, I'd like to remind you that there were few young men ophthalmologists too. And let me once again thank all of you for being here today. Kollam Ophthalmic Association believes in empowering the youth, giving them opportunities to share their thoughts and their perspectives in all the nuances of ophthalmology. And here we have in this session an array of young ophthalmologists who will tell us their ideas about various aspects of cataract surgery. I have with me a team of young and not so young dynamic cataract surgeons. Yeah, of course, Dr. Minu is nowadays sleeping in a car most of the time. He's traveling and operating, that is what I heard. And of course, Anup and your name, ma'am? Shruti, I'm sorry, Shruti. So let us listen to the young Turks. The first talk is by Dr. Sanitha Satyan. Somebody is going to introduce Sanitha, or am I supposed to? I am. You? Yes, please.
Let me introduce our first speaker, Dr. Sanitha Satyan. She is currently the medical director at Vettam Hospital, Mulanthuruthy. She has won several state and national level awards, and she has several publications in international journals. Let's hear her talking about biometry, doing it right.
Very good morning to all of you, and thank you, Shruti, for the introduction. And at the outset, I would like to thank the young ophthalmologist of Kollam and Kollam Ophthalmology Association for their, like Sir told, for their vision of empowering young ophthalmologists. So I'm going to talk about biometry, no financial interest. So we'll start with a spotter. Anyone? What is this iconic image? I don't have much time, so I'll give you a clue. Yeah. Dr. Harold Ridley, this is the first IOL which was implanted. The year was 1949. So, do you remember what was the refractive? Yeah, it was minus 18 diopters. We started from there. Now I'm going to talk about biometry, which is a very polished and fine tool in our hands. So biometry is basically the measurement of the eye, and we look for the interrelationship of the structures to determine IOL power. We know there are different kinds of keratometers, manual, auto keratometer incorporated to the ARs, and optical biometers, topography-based devices. These are pretty accurate manual keratometers, the good old Bosch and Lomb and Javel diodes. These are the automated keratometers which we use, and topography-based systems. So this is a point which we should note. Like, how do you validate your keratometry measurement? Suppose you got a keratometry which is towards the extremes of, it is less than 41 diopters or 47, more than 47 diopters. I suggest always remeasure the keratometry. And if the corneal diameter in extremes, also it's a good idea. And if you have a corneal astigmatism more than 2.5 diopters, always validate your measurements. If there is a difference of more than 1 diopters between the eyes or in the average corneal power, and if there is a poor correlation between corneal cylinder and refraction cylinder, always recheck your keratometry because it's going to affect your results. And axial length measurement is a very important thing. We have the ultrasound, applanation and immersion scans, and the optical biometers. We all know about all these things. And when do you remeasure an axial length? So suppose you got an axial length of a patient less than 22 millimeters. Please do recheck. And if it is more than 25 millimeters also, please recheck. And if there is a difference in the eyes between the axial length measurements of more than 0.3 millimeters, and there is no correlation with refraction also, please do recheck. And about optical biometers and the difference between ultrasound-based and optical biometers, how they measure the axial length, I think it is known to everyone, so I have just put in a slide. And one use of ultrasound biometers was in a case of very dense cataract where optical biometers had difficulty in penetrating. But with newer systems like Lenstar and IOL Master 700, this penetration is also improved. So there are different principles like a partial coherence interferometry in which IOL Master 500, AL scan by NIDEC and Pentacam works. Then the optical low coherence reflectometry, Lenstar, Aladdin, and Galilei works on this principle. Then we have the SWEP source optical coherence tomography, which is the basis of IOL Master 700, Argos, and iStar. So almost all the newer biometers, all of them measure these parameters: axial length, yes; keratometry, yes; ACD, wide to wide diameter, and some measure length, thickness, and pupil size also, because this comes handy when you are going to use different formulae for calculating the IOL power. So I thought this will not be complete without talking about IOL power calculation formulae also. So basically what you want to do, you want to predict the post-operative refraction based on the pre-operative data. The most important thing is one word, ELP, which is the effective lens position. You are trying to make a good prediction of the ELP, because ELP cannot be measured like you measure keratometry, like you measure axial length. What is ELP? It is the effective position where your IOL is going to settle after you do a cataract surgery. It's the distance between the anterior surface of the cornea and the lens plane if the lens was infinitely thin. So you have something called A constant, which is depending upon the type of the IOL, material of the IOL, and the design. That is given by the manufacturer. And you have a number of IOL formulae. There was a refraction-based method, regression analysis-based, which is the most common. We have all used SRK and SRK2 formulas. And then we have the Vergence-based formula, which is based upon the Gaussian optics. We have a lot of formulas. A few of them are SRK-T, Holiday, Hoffer Q, Hedges, and the Barrett Universal 2. Again, artificial intelligence based formulas are also there. Hill RBF, Clark neural network, and then you have ray tracing based ones also. Virgin's formula, again, they are divided into 2 variable, 3 variable, 5 variable, and 7 variable, depending upon the parameters which you are using to determine the IL power. And this is also important. This relationship between the anterior segment or ECD depth and the axial length need not be the same in all the eyes. This holiday schema is a very important thing to be understood. And nowadays, Barrett Universal 2 is a very robust formula for almost, it's called universal because it can be used for almost all of the eyes of different axial length. And it is based upon a theoretical model of the eye. And there is something called lens factor, which the formula calculates. And this is the Hill RBF online calculator. This, as I told, it's a artificial intelligence based thing. They are not using ELP as a measurement. What they're trying to find out is they have a nomogram of many eyes, and they are using artificial intelligence. It's a self-validating method. Actually, this is the website. You can, it's all available freely. You can go and enter your values. And if the software doesn't have enough number of eyes to give a robust IOL power, it will actually tell you that the validity is so and so.
2 more minutes left.
Yeah, that's okay. And in high myopic eyes, this is very important because when you fail to measure the actual axial length, the myopes tend to have some amount of hyperopia, which is very unacceptable. So Wang-Koch modification for high myopia is suggested. Most of this is incorporated into the newer biometers. And post-refractive surgery, almost every discussion carries this. So Barrett True K is actually a very good formula which you can use for post-refractive surgeries. And there are a number of other formulae, many of which are available freely, and some are unpublished. But this is a study, this is a journey which is evolving. And as I earlier mentioned, from -18 diopters, we are here. And we are going forward, refining our techniques in biometry. And thank you for your patient listening.
Thank you, Dr. Sanita. I think the organizers have told us to keep the discussion towards the end. Is that right? Okay.
Thank you.
Then we'll go ahead with the next speaker. So before I forget, to add on to what our Dr. Davis had told, there is another app called DigiNerve, DIGINERVE, that is edited by Dr. Prajna, who is the editor of Payment now. And that is like an interactive class. It's like a class being taken with videos, smart board, and then you can have tests and all those. So it's a paid one. It's made paid specifically because there are so many free ones are available. Still, it is paid. So it is worth downloading and going through that.
Moving on to some challenging situations in cataract surgery, we have Dr. Rohit Joji Matthew, refractive and cataract surgeon at Lotus Eye Hospital and Institute, Cochin. He was SICS and phaco trainer at Aravind Eye Hospital and has a record of performing 75 SICS in one day. Sir will be dealing with PC rents and pearls for anterior vitrectomy. Welcome, sir, and over to you.
Good morning all, and thank you for the invitation. So I'll just move on to the topic. So I'll be talking today regarding PCR and the pearls of anterior vitrectomy. So the first thought when you have a PCR is like, oh, it's again, same thing has happened. Or the next thing you're going to do is you just stop and you need to think what you need to do next, and you just calm down and don't make unnecessary sounds so that the patient will be more alert. And next thing is to proceed. So I'll just move on to the, skip the introduction and we'll move on to the posterior capsule, when it occurs. Like when the extension of the CCC occurs, or when a blowout of the hydrodissection or puncture with a phaco probe or puncture with a second instrument, or the sharp edge of a nucleus fragment getting a PCR, or trauma while inserting an IOL. The early signs are sudden deepening of the anterior chamber and the dilatation of a pupil, a transitionary appearance of a clear red reflex appears on the periphery, and the inability to rotate the nucleus. Even the partial descending of a nucleus can happen, and the occlusion sound of the phaco machine occurring without any nucleus or cortical matter at the tip. So when does it get more worse? The hyaloid phase gets ruptured. So what other tests can be done to rule out is a sponge test to know the vitreous is there in the section, a stain with the triamcinolone acetate, air bubble, or an iris sweep with a spatula. So the management strategy, already I told, just stop, don't panic, stay calm, take deep breath, and next thing is to assure the patient that it may take a little more longer, and ask the sister to get ready with the AV set. Don't tell them like get ready with the vitrectomy, because patient might go home and search on Google. So just tell AV set, and wait and think for the next step, and see what is the extent of the PCR and the intactness of the hyaloid phase. Locate of the nucleus, whether it's dislocated into the anterior phase, means the vitreous, and the availability of the IOLs, secondaries, and check whether the VR surgeon is available in the hospital right now. The goals of the management of PCR is to avoid posterior dislocation of the nucleus, fragments, remove the cortical matter, and prevent any damage to the cornea endothelium, and see what is the extent of the tear, and minimize the size of the vitrectomy by avoiding the traction, the removal of the left tower cortex, and implantation of the IOL. The earlier response to PCR will be sudden unplugging of the incision, which results in emptying and collapse of the anterior chamber. So it will be done very slowly. And instead of the anterior chamber should be filled with the viscoelastic with a side port, and the should stay in a foot pedal of 1 as the viscoelastic is injected, slowly make it to 0 and withdraw. So what you need to use a vitrectomy probe of 20 gauge, and use a maximum possible cutting rate, and the flow rate should be reduced. The vitrectomy cutter should be in advanced or held in stationary during anti-vitrectomy and never pulled while cutting. So these are the previous parameters, means old machines like Lorette and Infinitive. The cut rate is 1500, Infinitive will be 2500. There are two ways in a Lorette and Infinitive, like cut IA and IA cut. What I use right now is a Constellation, where the cut rate is 5000, and the vacuum I keep is 250, flow rate is 20, and the irrigation is 60. The position of the cut IA, first one is irrigation, the second position will be irrigation plus cut, and the third will be irrigation, cutting, and aspiration. So cut IA mainly for the vitreous to be cut, and IA cut is for the cortical. So IA cut, we will do the first position will be irrigation, the second position will be irrigation plus vacuum, and the third will be irrigation plus vacuum and cutting. So bimanual technique is the one I use more preferably. The irrigation port in the AC above the cutter, and the vitrectomy tip is inserted through the opening in the posterior capsule and placed mm or 2 behind the posterior capsule. The aspiration port is directed upward towards the cornea, and preferably the vitrectomy probe should be a little bit lower to the PCR, so that the anterior vitreous which is in the AC can be pulled down. So next, what to do? IOL placement. Make sure the pupil is round. Be certain there is no vitreous in the AC, and the wound is sealed. Evaluate the intactness of the capsule, anterior capsule, and evaluate the extent of the PCR, and see whether any residual cortex is left over or not. If the PCR is less than 6 mm, it's preferably better to put the IOL in the back. If it's extended, it should be kept in the celia sulcus, and keep a optic capture. The IOL should be always placed 90 degree away from the axis of the tear. If the IOL shows signs of poor fixation, it's better to move on to a iris claw or a SFIOL. So what is the calculation usually for a IOL to be placed in the sulcus? That is, if it's plus 5 to 9, no change in the power. The availability of the lens will be difficult. And if it's 9.5 to 17, a 0.5 can be reduced diopter. If it's 17.5 to 27, 1 diopter should be reduced. And 27 to 35, 1.5. It's all depending upon the constant. The wound closure should be done with a 10-0 nylon, that is for sure. And injecting a pilocarpine will be better to know any tag is there. And additional cannula can be injected, like triamcinolone acetate, and iris sweep after finishing the surgery. So what all should be checked? Vitrectomy consumables and sterile set, 10-0 nylon, and viscoat, and triamcinolone and pilocarpine. So what is the conclusion? Identify the presence of predisposing factor, Mendel preparation in advance, and earlier recognition and treatment of capsular tear and vitreous loss. So I'll just move on to the video. So this is a case where a rent happened in a hard cataract. Towards the end, I aspirated with the bimanual technique. So the hyaloid phase was not much disturbed. I removed the leftover cortex and I did a vitrectomy below and tried to convert it into a posterior cyst. And once the vitrectomy part is done, I implanted a single piece IOL in the bag itself. So always when you implant an IOL in the bag after PCR, you should make sure the vitreous is not left over in the AC. This is a condition where same PCR has happened and I implanted a rigid IOL because the package of the patient was a little bit lesser, so I had to implant a 3-piece rigid. In fact, you can use a foldable 3-piece also. Once the lens is implanted, vitrectomy again done over the pupillary area and just hydrated and put a suture. Make sure the AC is well formed. Next case is a referred case. Actually, the patient had a zonular dialysis while doing the surgery. So there is a vitreous tag. So I've done an anterior vitrectomy.
Dr. Rohit, can you wind up?
Sure.
Thank you.
And just moved the lens, rotated the lens. So just 30 seconds more. And implanted a CTR. Can you fast forward it? And next case is an iris claw, where the patient was referred from outside, where the IOL was in the anterior face of the vitreous. I did open the section and remove the IOL. Sure, sir. Sure.
Yeah, I think you should be fair to the next speaker.
Sure, sure.
Thank you.
Okay. Sir, done this. Sir. Huh?
Now let me introduce.
Okay, sir. Thank you, sir. Sure.
Thank you, Dr. Rohit. Let me introduce the next speaker, Dr. Grishma MG. She did her MBBS and MS ophthalmology from JIPMER. She was awarded a gold medal in the Madras Ophthalmic Conference. She is currently working as assistant professor in RIU Trivandrum. Dr. Grishma will be talking on transition of tackling the transition from SICS to FACO.
Good morning to all. I thank Kollam Ophthalmic Association for this opportunity. So let me come to my presentation. Yes, how to tackle your transition from SICS to FACO. So first step is obviously to master your small incision cataract surgery, and you can bring about small changes which will help you to become a better FACO surgeon. You can switch to a subtenon block so that you are confident with a topical FACO. You can shift your incision to a supratemporal or a temporal incision and master your rhexis. And the add-ons required are you have to learn to use your non-dominant hand. If you are a right-handed person, you can brush with your left hand. You can write a paragraph or two daily to increase the flexibility of your non-dominant hand. Learn your audio, listen to the sounds from the machine while you are in OT and regulate it with the foot pedal. Know your FACO machine well, whichever is in your institute, you know your machine. And the basics of FACO dynamics, you have to keep an eye on your bottle height. See what energy is being used, whether it's a longitudinal or a torsional energy, the mode being used. Regulate your aspiration flow rate and vacuum so that your anterior chamber is well maintained. And take necessary steps to minimize the surge. So this is very important for a beginner surgeon because this is the one thing which is entirely different. So there are actually 3 positions for the foot pedal, as you can see, and the position 0 is the rest position where there is no irrigation, aspiration or FACO happening. And when you press the foot pedal further, you go on to 1 where there is only irrigation. So that you can use it to rotate the nuclear pieces or manually separate the nuclear pieces. And in foot pedal 2, you have the aspiration. The nuclear pieces are attracted to the FACO tip. So that can be used to grip on the nucleus. You can use it during chop and emulsification. And you get a high pitch when the tip is totally occluded. And at foot position 3, you can use your FACO energy. So emulsification is actually a interbalance between your foot pedal 2 and foot pedal 3. You have to attract your nuclear pieces with foot pedal 2 and emulsify with 3. For a safe FACO for a beginner, you always have to choose a good case. The patient should be the pupil should be well dilated with an NS2 or 3 cataract and an uncomplicated case. Always work in your central safe zone, that is which is regulated by your CCC, usually around 4 to 5 mm. Titrate your parameters accordingly to stabilize the anterior chamber. Judicious use of your viscoelastics is very important. While doing a rhexis, you can use your Cohivisc, and while you are doing your FACO emulsification, you can coat the endothelium well with a visco dispersive. And the positioning of the FACO tip is also very important. Always be in the central safe zone. See the orientation of the FACO tip at what step you are doing. So this is a clear corneal. This is a scleral incision that is usually comfortable for a beginner. You can first make a scleral pocket with a crescent blade, and then with a keratome you can make the entry. If you are comfortable, you can make a clear corneal incision or a limbal incision. This is a rhexis. In this, mature cataract is shown where double rhexis is being made. If you feel that rhexis is small, you can make a double rhexis like this. Because a smaller rhexis, usually what happens is that the nucleus management becomes difficult. So the second rhexis is made by cutting with a micro rhexis scissors and then pulling off the flap with the micro rhexis forceps. So a good hydrodissection is very important. You have to ensure that the nucleus rotates properly after hydrodissection, and the hydrodelineation is also done because you have a epinucleus sheet which will protect the PC. So the nucleus management is entirely different in FACO. Usually a beginner starts with a divide and conquer technique where you first make an initial groove. While making the groove, you have to be careful about some things. That is, you have to be in the linear mode of phaco, or you can put on the hyperpulse mode. You have to lessen the vacuum so that you are not attracting the nucleus towards your phaco tip. And while doing, don't do it linearly. You have to have a concave orientation of your phaco tip because the lens thickness is centrally more. And while using phaco energy also, use foot pedal position 3 in the forward stroke. But while coming back, you need not have any phaco energy. So you can be in 2 or 1 while coming back. And once you have the initial groove, you can rotate the nucleus 180 degrees and make a second groove. And once you have this plus sign, as you can see, you can place the instruments, 2 instruments we usually place. In the depth of the groove is very important, and then separate the nuclear pieces. And completely separated quadrants is very important because the posterior plate, if it is intact, you will have difficulty while quadrant removal. So these are the parameters usually kept. It depends on your phaco machine also. And once you are comfortable with the divide and conquer technique, you can move on to your stop and chop. For that, you only have to make the initial groove, separate into 2 halves and not quadrants. And once you have the halves, you can chop the each half. And direct chop, you have vertical and horizontal chop. This is a vertical chop wherein the phaco tip is embedded deep into the, impaled into the nucleus and chopped to create a crack. And this is a quadrant removal where each quadrant is emulsify, ensure a proper separation of the fragments before you do the quadrant removal. These are the parameters used. And be prepared to deal with some difficult situations like runoff of your axis, or the anterior chamber becomes unstable, or any bowl formation. So you have to have a backup plan for all this. And the learning continues with a mental rehearsal because your foot control is also important. You have to train in your wet lab. You have simulators available, not in every institute, but if you have, utilize them. CMEs are good teaching programs will be there. Surgical videos are very good teaching videos are there. Innovative videos, like my friend Dr. John has put up one YouTube video. You can see that, a kitchen ophthalmic surgeon it is named. So where the raw materials in the kitchen are used to improve your surgical skills. Thank you. I especially thank Dr. Neeta Madam, Dr. Shivkumar Sir, John, and Dr. Niruban for helping me out in this presentation. Thank you.
Thank you very much, Dr. Grishma. We are on time. Congratulations. I think it is very important that speakers, when they come on stage, anybody at any age, they should stick to their time. Some people, just because they are seniors, they will talk continuously for 25 minutes when they are given 10 minutes. In any forum, when you are given a specific time, try to practice at home your timing, which is equally important, so that you don't go beyond. This is a very important point as far as conferences are concerned, because then otherwise the next speaker is put into unnecessary. You are reducing the time available for them to speak. Thank you so much, Dr. Grishma, for that wonderful talk. And then finally we'll come to Dr. Vanishri Nair. She will talk to us on phaco in complicated cases. You will introduce Dr. Arya? Vanishri.
Next we have Dr. Vanishri Nair, Consultant Cataract, Refractive and Anterior Segment at Giridhar Eye Institute, Cochin, Center Head, Giridhar Eye Institute, Tripunitura. She will be guiding us with her expertise in phacoemulsification in complicated cases. Her areas of interest being complicated cataract surgeries, topical phaco, and refractive surgeries. Welcome, ma'am.
Thank you so much, Kollam Ophthalmic Society and the young ophthalmologists over here for giving me this opportunity to speak in this very nice CME today with a full hall here. So let me begin without wasting much time. So when we say that difficult situation, so what comes to mind are many situations, but I would like to elaborate on few of them here. I think one of the most common ones that we face is pseudo-exfoliation, and to begin with, we do not know whether there are going to be weak zonules or not. Intumescent cataract, again a very common scenario. Polar cataracts, small pupils associated with IFIS, diabetic, very hard leathery cataracts are some of them that we come across. Coming to the video, now this is a case of a pseudo-exfoliation, As you can see, the pseudoexfoliative material and the left eye is what I'm going to operate, and the ACD was shallow. So I knew that this is going to be a difficult case. So here, as you see, as I began, there is a, I'm forwarding the video a little because there is a lot, it's a big video. So important sections I would like to show. So here the pupil was small to begin with, and I knew that the zonules are weak. So I wanted good visualization. So what I decided is, let me go ahead and put a pupil expansion device. Here what I'm using is a Maligan ring. And as you can see, I have placed all the scrolls, and now I've got a good visualization here. Now as I begin the rexus, you can notice that the whole system is moving. I'm not able to start my rexus at all. And I injected some more viscoelastic to again flatten the AC, but as you can see that here I just start my rexus, and then I shift over to the micro-rexus forcer because I know that further on it will create problems. So as I moved ahead, you can see that I needed some counter traction with another micro-rexus forceps because the zonules seem to be weak all over in 360 degrees. When I began, I didn't know that it will turn out to be a very difficult case. But as I went ahead, now you can see with my right hand, I'm able to proceed ahead with the rexus here. Patience is the key. You have to be patient. And as I did the hydrodissection and put visco, I felt that since the bag is weak all over, I need to give some extra support. So I thought of using the capsular hooks which give anterior-posterior support to the bag so that when I'm doing my phacoemulsification, I will not disturb the zonules more. So in a package, you get 4 capsular hooks. I placed them and I began my phacoemulsification. Stop and chop is the preferred technique. The cataract was soft here. What I wanted was I don't create a bowl and have a trench, but to my bad luck, it was a soft cataract and I landed up eating it more. So excessive manipulation would have caused trouble. So what I thought is, let me put the CTR before the phacoemulsification is over. And I use this manual technique of placing the CTR. The point to remember here, when you're doing phacoemulsification and the nucleus is not completely out, and if you want to put a CTR, better to put some viscoelastic to create space. A cohesive one is better. I had the CTR in place now, and I'll just forward it a little. At the end of nucleus management, here now you have some cheesy cortex, and because the CTR is already in place, it is difficult to take the cheesy cortex out. But the important thing is to go tangentially, and again, have some patience, go slow. I'll forward it a little. And then at the end of it, I managed to put a 3-piece IOL in the bag. The reason being, it was a pseudo-exfoliation case. I wanted to put a 3-piece lens in this case. That was the end of it. Coming to the next situation, intumescent cataract, a very important situation. Here, when my technique is to go for a double rexus. Why a double rexus? Right in the center, create a very small opening, and now you see that there is no egress of fluid. That means that fibers are all tense in the mid-periphery. So you have to go in and decompress those fibers from the mid-periphery. You can go from multiple directions, use both your side ports. I use a hydro cannula so that you have a small cannula going in. Once those fibers are decompressed, then you proceed ahead with your extension of the rexus. So I made the main port, use a micro-rexus scissor, create a tangential cut, avoid creating a radial cut, and then slowly begin and aim for a moderately sized rexus. Don't try to aim for a very large rexus here because there's a high chance you'll go for a rexus extension. Now the important thing over here is you have to put viscoelastic in between to keep flattening the rexus. I use the second hand to proceed ahead because that gives me a better directional control of the flap. And here I feel again I'm not able to move ahead, so I put viscoelastic, keep the capsule flat, and then complete the rexus. Further phaco is like a normal mature cataract. Now here is a Morgagnon cataract. After my double rexus creation, if you see, when I try to go for the creating a central pit or even creating a trench, the whole nucleus keeps moving. So here it becomes a difficult situation because you're not getting a hold on the central part of the nucleus. So you have to be a little more patient. What you can do is with your sharp chopper, you can take a grip on the nucleus, or once you have a central pit, hold on over there. And here the thing is your vertical chops don't work. So what you need to do is actually a horizontal chop. So take a grip and then go up to the periphery and then take the chop. So once you have the chop, you sub-chop it and then you eat up the nucleus. When you come to this last piece, it is important to be careful because a sudden surge may give you a rent. So inject viscoelastic and then eat up the last piece. Coming to another important situation, that is a polar cataract with a soft nucleus. So here you have, I've made the rexus. An important thing to remember is no hydrodissection, only a slow, gentle hydrodelineation so that a central core gets separated. And a gentle, you can do a manual separation of the capsule with the help of a blunt iris repositor. When you start the phaco, I prefer to create a very small central trench so that you can try and divide this nucleus and then eat up the epinucleus. I'll just forward it a little. Here, what happens is you have a large chunk of epinucleus left, so how to manage that when you have a polar cataract? You can use viscoelastic to separate the epinucleus, and then, and one very important point is every time you come out, you have to inject viscoelastic to maintain the anterior chamber. In any complicated situation, the most important thing is maintaining the anterior chamber. Do not let your anterior chamber collapse, because that is one important thing in a polar cataract or even a zonular dehiscence or even a PCR. You allow the anterior chamber to collapse, and that makes the vitreous come up and complicate the situation more. So that's one take-home message that I would like to say. I would not go to IFIS scenarios. One thing that I would like to say in the end is, sometimes even a simple case may complicate due to some of the iatrogenic mistake that we make, but we need to have a backup plan how we are going to tackle it. A difficult case may go uneventful because you have thought it through, and you have used the right technique and you have been vigilant. So important thing is have a backup plan, anticipate the difficulties, stay calm. One thing that I recently came across, one of the speakers at a national conference, was what he said is, there are 3 stages of evolution as a surgeon. First stage is where we have no idea what is happening. We are just, the situation is totally controlling us. We are just going ahead, operating blindly. If it went well, fine. The case went well, very happy, I came out. Second stage is, some things can go wrong, and you keep praying to God, oh God, please, hopefully no complication happens, no complication. But if something happens, you just give up and you come out. And stage 3 is when you have an idea, you anticipate, you plan, and you act. You control the situation. That is the time you have really mastered the art. Thank you.
Thank you, Dr. Vanisri, for that excellent talk. I think this is open for discussion. How many among you are using an optical biometer? Raise your hands, please. 2 and 3, 5. Okay. And A-scan biometry? Okay.
Ultrasound means immersion. How old are you?
Fine. And do you want to make a comment on this comparison between an immersion A-scan versus an optical biometer?
Actually, I don't have any experience with this optical. I don't have actually. Immersion works well for me.
I have access to both, and we have done for a postgraduate paper. We have done a comparative study. So these are almost same. So optical and well done immersion are almost the same. So only thing is, the technician who does this has to be consistent, and he has to. You have to validate his or her performance, or 2 of them should be there. One person, if not there, the other person should do. If done well, both are equally good.
I have also one thing more to add to that. I have published a paper on this. Even contact, this is very important. Even contact done properly in regular cases, which are maximum number of your cases, will give you perfect results. So don't think that contact is bad, but know when to go for immersion.
That is very important.
Done by Dr. Marin or by an optometrist?
No, I have done all that by myself. But important thing is to know how it is done. You see, when you get the printout, you know whether it is done properly or not. So you should know how to read the printout.
Okay.
That is the important thing.
That is where I think a structured biometry course is very important. Kollam Ophthalmic Association is planning actually to have a structured biometry course in the near future we are discussing, where we'll train people to do biometry properly so that the results are better. It has been documented that training really helps in improving the results, like getting plus or minus 0.5 to 92, 93% of all patients. Training is very crucial. Anything else?
Sir, getting this 0.5, actually there was a talk by Robert Koch, and he also said 70% of his cases are only within 0.5. So if you get within 0.5, you please believe yourself that you are in international standards. So no, don't be unhappy about that. And the formula, I want to make one point, that the Barrett Universal 2 is available freely. And many people who have converted to that are very, very happy with the outcome. And if you measure properly, please use the Barrett Universal 2, which is freely available online, and it gives excellent results over all axial lengths. So we move on to, yes.
Find the effective lens position. So that is the beauty about the optical biometer, not just the accuracy of the axial lens alone. That's what I feel about it. That's what take I have.
See, effective lens position is definitely, of course, is a much discussed and hyped point in this. Most important is, of course, the anterior chamber thickness, the axial length, the keratometry, and the anterior chamber depth, of course. But please remember that the effective lens position varies in the same eye, because once the lens goes into the shrink wrap effect of the capsule 1 month or 6 weeks after surgery, then that position once again changes. And 2, when the vitreous undergoes degeneration, the position changes. So the ELP is not exact, this is not exact physics. So that position is not that relevant. That is what I feel. And second thing is, of course, it is important when we change from an interbag lens to the sulcus, then definitely you have to change the power of the lens depending upon the position. In that, I think ELP really plays a role.
An immersion technique will do.
Immersion will do. If done well, immersion will do. So don't take home the message that optical undengile karyam nadakku, nothing like that. So if done well, as Madam was telling, there are many people who are using very effectively the contact one, but the problem is that it varies drastically with the people who are doing it, and they don't look at the graph. The graph which comes on the printout has to be looked carefully, and if that is not correctly done, then you change it and you should read that also. So we don't have time much. We're going on to the PCR part. I think 2 minutes will be given, I think. No? So PCR part, the 2 or 3 points which I want to make clear is, in SICS also you get PCR. It was told only for phaco, but in SICS also you get PCR. So the point is not to do a vitrectomy through the main port. So whatever size of your vitrectomy port is, please make a paracentesis of that size. You can use 20, you can use 23, 25, whatever is available, but it should be a cutting one and should be made available. And I have changed 3 vitrectomy cutters on a case with a piercer and with the vitrector not working. Sometimes only the trrr sound will come, it will not cut. Sometimes it will cut, it will not aspirate. The technician will not throw it away. So please ask them to discard in front of you and open. It won't cost you. Later on, problems will cost you more if you do not keep a vitrectomy probe with you. And the use of triamcinolone acetonide, it is very important towards the end probably. But then if you put a lot of it into the vitreous, after a vitrectomy, it just sinks into the vitreous and causes a lot of IOP spike later, uncontrolled IOP spike. So judiciously use it where you have a doubt, and need not use it in the beginning also. and the use of viscoat. I don't have any financial interest. Oro code, Appasamy also makes that, but then dispersive viscoelastic is very, very crucial to plug areas which have PCRN. See, all the signs of vitreous loss is different, but a PCRN alone is different. So the nucleus not rotating in an SI, in a phaco, that is very crucial. If it doesn't rotate in the direction if to touch it, it goes to one side and then it comes back, or it tilts. These are the early signs. Vitreous coming and blocking, and you're getting a distorted pupil, deepening, all those happens with the vitreous coming out. So you should stop vitreous from coming out, and then keep a watch on the posterior capsule and the red glow, which you see. Sometimes you see very bright red glow just by separation itself. And keep in mind that there can be a posterior polar which can be hiding behind these kind of hard cataracts, and they can give way in the beginning itself, first chop itself. And dissociating irrigation, keeping it at the higher level, not to aim it towards the PCRN. And it is also very important not to bring out more and more vitreous. And the cut rate has to be maximum on what you can get in your machine. So it can be a lower end machine also which can give you the maximum cut rate. And don't use this aspiration cut rate. I don't use that. Cutting and then aspiration for vitreous, and if you need to aspirate, just aspirate with your bimanual. Change the cutter and use the bimanual IA. And if you get vitreous, you need to do a vitrectomy again. So because the aspiration port is very large, and to occlude onto cortex, it is very difficult it takes time, and it is difficult. It can catch other iris and the flaps of this one.
I also don't use this triamcinolone acetate. it actually gives bad experience to me. Without triamcinolone acetate, it works well actually.
Towards the end, I think we can use, but one thing I'll suggest is you should always use diluted triamcinolone just for us to see, that's all. And use a small 1 cc syringe to inject, so that you don't inject a bolus of tricot into the vitreous, because it will stay there and it's not easy to pick it up. And another point I want to highlight is, if you have a bit going down into the vitreous, please don't go behind fishing from the vitreous. This is very, very important. You will enlarge that PC opening, and you will create a lot of vitreous traction to the base and produce retinal tears and detachment. And that is another thing. And then see that you should always, whenever you are operating, right from the time that you do your hydrodissection, from then on you have the risk of a PC opening. You should always have a third eye watching for that PC opening coming. Will it happen? Will it happen? And finally, when you come to the last stage of emulsification, that is when you come to the fourth part, the last bit of nucleus to be emulsified, please bring down your vacuum. Please bring down your flow rate. I operate at 100, at times 75 for my last piece, so that your AC still remains stable. Because the PC will, or by the time you have manipulated, you have chopped and you have divided, the sonules go weak and the PC comes up, it becomes convex. At times with the weak sonule, you may have fluid going behind and you will see small particles there, it will also push up. So when you come to the last stage, inject viscoelastic, bring down the vacuum, and then finish off the last piece. In case you have a small bit, the AC is shallow, don't worry, you inject visco, use 2 dialers and just take it out, the final piece. So these are the few points I want to tell regarding PC errands. And if you think that your PC is not adequate enough to keep that IOL in position, please anchor. Please anchor.
So 3-piece IOL, I always have three IOLs. I have 3 IOLs in backup. And the 3-piece IOL, you don't place a single-piece IOL into the bag if you don't have a continuous rhexis margin of the posterior. This is a number of clock hours doesn't matter. If it is some irregularity is there, it will extend. It is your luck if it doesn't extend. So please I have 3 lenses. A single-piece lens, if it is so, the same power, one more, and a 3-piece lens backup for every case. And if it is inferior, I never place a single-piece IOL into the bag, only a 3-piece IOL into the sulcus.
I want to make a comment about the transition from SICS to phaco. So during my initial cases, the major challenges were the use of left-hand instrument. So in most of the initial cases, it was like a silent spectator, not doing much. And we have to be very careful about the use of left-hand instrument. We have to, as we gain experience, we'll learn how to use it more. And the second thing was about the use of foot pedal. That also needs a lot of experience. And the third thing was the aspiration of cortex through the small pot, which is different from the SICS, which is a larger incision, and the larger tunnel, we have a lot of area to aspirate, to manipulate the instrument. And this was also a difficult thing in the beginning for me.
I'll make one final point on pseudo-exfoliation surgery that Dr. Vanasri showed. See, when you have that much of weakness, that much of weak sonules, implanting the lens into the back may not be a good option. That is what I feel. I always implant in such situations into the sulcus because pseudo-exfoliation is a continuing progressive damage. So it can always drop in. So just a CTR will only stabilize for the time being. Over time, particularly if the patient is little younger, if the patient is 85, you can take a chance. But otherwise, you should always put the lens in the sulcus because if it descends, it is easy for us to anchor it to the iris. That is one point I want to make, and with that, let us conclude this session. Thank you very much. Let me thank my co-chairs and the moderator. Thank you, Kollam Ophthalmic Association. And I think all of you should get your hands together for one man who is behind this entire show, Dr. Rajiv Sukumar. Please. I think you need to give him a standing ovation. A standing ovation. Yes. Thank you so much.
For inviting me and making me understand that I am not in this young ophthalmology group and I have transformed into adult ophthalmology group.
Next, we have the memento distribution. May I request Dr. Rajesh Sukumaran sir to hand over our token of appreciation to Dr. Jayaprasad sir. Thank you, sir. Dr. Minu Matan, sir. Thank you, sir. Dr. Anup Bahulayan. Thank you, sir. Dr. Sanida Satyan. Dr. Rohit Georgie Matthew. Thank you, sir. Dr. Grishma MG. Thank you, ma'am. And Dr. Vanashri Nair. Thank you, ma'am.
So we came to the end of session 2. Thank you so much, audience, for your patient listening. Now it is time for the official inaugural function. So before that, കേരളത്തിൻ്റെ വാനമ്പാടി, മലയാളികളുടെ സ്വകാര്യ അഹങ്കാരം, ലക്ഷങ്ങളുടെ ആരാധനാപാത്രവുമായ KS ചിത്ര, നമ്മുടെ സ്വന്തം ചിത്രചേച്ചി 60ാം പിറന്നാൾ ആഘോഷിച്ച വേളയിൽ എല്ലാവിധ ഐശ്വര്യവും ആയുരാരോഗ്യ സൗഖ്യങ്ങളും നേർന്നുകൊള്ളുന്നു. ആ മഹത് വ്യക്തിത്വത്തിന് ആദരവെന്നോണം ചിത്രചേച്ചിയുടെ പ്രശസ്തമായ ഗാനങ്ങളിൽ ഒന്ന് നമുക്ക് ശ്രവിക്കാം.
സ്വപ്നത്തിൽ ഞാനൊരു പൂമ്പാറ്റയായിന്നു മാറി. പുലർകാല സുന്ദര സ്വപ്നത്തിൽ ഞാനൊരു പൂമ്പാറ്റയായിന്നു മാറി. വിണ്ണിലും മണ്ണിലും പൂവിലും പുല്ലിലും വർണ്ണച്ചിറകുമായി പാറി.
Friends, there will Sibilia Karupam from Kollam Medical College, and finally Dr. Dimple Rose and Dr. Arya A.H. from Kollam Medical College. So all the very best to the 4 teams. You will be called in later after the inauguration. Thank you.
Good morning to one and all. We are honored that everyone could join this auspicious occasion. It is with immense pleasure that we welcome you to YOLK Insight, a one-of-its-kind CME organized by the Young Ophthalmologists of Kollam.
We are privileged to launch this KSOS President's Program, which was made possible by the God grace, blessings of our seniors, and the hard work and dedication of our young members.
I humbly invite the KOA President, Dr. Mini Jayachandran, to the dais.
I consider it a great honor to welcome the President, Kerala Society of Ophthalmic Surgeons, Dr. Sai Kumar S.J. onto the dais.
A warm word of welcome to Dr. Shiny Napoleon, the KOA Secretary. Please come over to the stage, ma'am.
I would like to extend a warm welcome to the KOA Treasurer, Dr. Vishnu Mohan.
I am immensely pleased to invite Dr. Divya Kishan, the Organizing Chairman, YOLK Insight, onto the dais.
With equal pleasure, welcome Dr. Rakhi D. Cruz, the Organizing Secretary, YOLK Insight, onto the dais.
The next dignitary to honor our stage with her presence is Dr. Divya S. Iyer, IAS, the District Collector, Pathanamthitta. I request you to occupy the honorable chair on the stage, ma'am.
Before the inauguration, let us invoke the Almighty, and for this I invite Dr. Anjana for the devotional Vandanam.
ജഗദീശ രക്ഷിക്ക ഞങ്ങളെ എന്നും മഹിതമാം ഭക്തിതൻ ജ്ഞാനമിന്നേകി മനതാരിലെന്നും വിളങ്ങണേ ശുദ്ധി ചിരമായി വളരട്ടെ ഞങ്ങളിൽ ഭക്തി സമഭാവ സർഗങ്ങൾ തന്നീരൊഴുക്കി ഹൃദയങ്ങൾ സ്നേഹാർദ്രസാഗരമാക്കി കൈകോർത്തു യോജിച്ചു മുന്നോട്ടു പോകാൻ സകലേശ ഞങ്ങൾക്ക് സദ്ബുദ്ധികൂ ജഗദീശ രക്ഷിക്ക ഞങ്ങളെ എന്നും മഹിതമാം ഭക്തിതൻ ജ്ഞാനമിന്നേകി.
Thank you, Dr. Anjana. I invite the Organizing Chairman, YOLK Insight, Dr. Divya Kishan, for the welcome address.
Good morning, everybody. Respected President of Kollam Ophthalmic Association, Dr. Mini Jayachandran, Chief Guest of the Day, Dr. Divya S. Iyer, IAS, KSOS President, Dr. S.J. Sai Kumar, other dignitaries on and off the dais, and my dear friends. We, the youth of Kollam, are privileged to launch this KSOS President's novel program, which is a CME that is organized by young ophthalmologists, and we have included in that only young speakers. And for this CME, first of all, let me welcome our dear President of Kollam Ophthalmic Association, Dr. Mini Jayachandran. As you know, KOA is now under the able and dynamic leadership of Dr. Mini Jayachandran, who is a constant source of motivation and support for all of us. A warm welcome to you, Madam. For the inauguration of this youth program, we wanted a youth icon. And we are indeed proud and privileged to have with us here none other than Dr. Divya S. Iyer, IAS. She is the district collector of Pathanamthitta. Dr. Divya Iyer has been in the forefront of Kerala's administrative and cultural arena and has carved her niche as a real youth icon of Kerala. We are so happy to have you here, madam. A warm welcome to you. Our respected KSOS President, Dr. S.J. Sai Kumar, is the brain behind the CME. It is a President's program of conducting a novel CME by the youth and with the young speakers that has given us this opportunity. On behalf of Kollam Ophthalmic Association and YOLK CME, I welcome you to this program. Dr. Shiny Napoleon is a very meticulous and dedicated person, is a secretary of the Kollam Ophthalmic Association, and she has been instrumental in all the recent achievements of KOA. On behalf of YOLK CME, I welcome you to this program, madam. May I also take this opportunity to welcome Dr. Vishnu Mohan, Treasurer of Kollam Ophthalmic Association, who has put in a lot of efforts for the conduct of the CME. Warm welcome, Dr. Vishnu. The veteran KOA leaders are our inspiration and strength. I'm really thankful to them for their courage and broad-mindedness in entrusting this big responsibility to we the youngsters. Dr. Rajiv Sukumaran and Dr. Jayaprasad sir are the two pillars of strength of the Kollam Ophthalmic Association. I'm proud and happy to welcome all the senior KOA members, Dr. JP sir, Dr. Rajiv sir, Dr. Jayasree madam, and other dear KOA members to this meeting. Let me also welcome speakers and panelists who have accepted our invitation and have come here today to make this program a very memorable one. Thank you so much, and a warm welcome to each and every one of you. Dr. Rakhi De Cruz, the dynamic organizing secretary, has put in tremendous efforts for the organizing the CME. Also, the committee members of the CME, a bunch of young ophthalmologists, have put in their heart and soul to make this into a real youth festival. A warm welcome to each and every one of you. Let me also welcome our trade partners, Zivira, for organizing the travel as well as sponsoring the quiz, and the other trade partners like Entod, Rhine, Ostrak, Cipla, Sunways, and Sun Pharma, who have contributed to the conduct of the CME. And I also welcome the audiovisual team, the hotel management, and the event management to this CME. Last but not the least, let me welcome my dear delegates, my teachers, seniors, colleagues, and dear postgraduates who have come here today to make YOLK CME a grand success. A warm welcome to each and every one of you. Thank you.
Thank you, ma'am. I welcome the KOA President, Dr. Mini Jayachandran, for the presidential address.
Good morning and warm welcome to all. Respected Chief Guest, Dr. Divya S. Iyer, IAS, KSOS President, Dr. S.J. Sai Kumar, other dignitaries on and off the dais, and my dear friends. It is with great pride and happiness that I am standing before this audience here as President of Kollam Ophthalmic Association. For the first time in the history of KSOS, a CME is organized by the youth of KSOS. It was Dr. Sai Kumar, a KSOS president, who gave us this idea when he visited our club after becoming the president. Our young team of ophthalmologists has put in a lot of hard work for organizing this CME. We took up this challenge, and Kollam Ophthalmic Association is bearing the whole expense with some support from pharma companies. Our association has a membership of above 100 now with the arrival of our young team. Our association bagged the Best Non-Metro Club Award during Drishti 2022, which was held at Calicut. We had academic programs every month and a family get-together after a long time last February. During the Glaucoma Week in March 2023, we had Glaucoma Awareness Walk, radio talks and camps, and seminars in which many of our members participated. KOA celebrated Women's Day in March by conducting an online webinar on 10th March, in which Dr. P.S. Shrikala, Director, Kerala Knowledge Economy Mission, was the speaker. KSO's President, Dr. Sai Kumar, inaugurated the very interactive session. During AIOC, which was held in Kochi in May, many of our members presented papers and participated in cultural events. I thank all members of our association for their participation and in all our activities. I should mention few names without which my job will be incomplete. Dr. Rajiv Sugumaran, who has been a strong pillar of support, and Dr. Jayaprasad, Dr. Shaini, our hard-working secretary, who has played a very important role in all these activities. Dr. Vishnu, our treasurer, and Dr. Jayasri Rajiv, who is always behind the scenes, but she is always coming up with new ideas to promote this association. Thanks to all members of KOA. Thank you all.
Thank you so much, ma'am. I would like to welcome the Honorable President of KSOS, Dr. Sai Kumar S.J. He is a medical superintendent and head of cataract and glaucoma, Giridhar Eye Institute, Cochin. He has more than 20 years experience in cataract and glaucoma subspecialties. Also has conducted instruction courses and made number of presentations in many international, national and state meetings. He has held many posts in Kerala Society of Ophthalmic Surgeons, including editor journal, editor website, and chairman scientific committee, and as honorary secretary. He has given lead for many research projects in ophthalmology. Recently, he has achieved the record of completing 50,000 cataract surgeries. We feel honored to have you here, sir. Welcome.
Good morning and a warm welcome once again to all the delegates, dignitaries present here. Respected Chief Guest, Dr. Divya S. Iyer, IAS, Collector of Pathanamthitta, Dr. Mini, the President of the Kollam Ophthalmic Association, other office bearers of Kollam Ophthalmic Association, Dr. Divya, Dr. Rakhi, Dr. Shaini, Dr. Vishnu, all senior members of the KSOS and my dear friends. Before I begin my presidential address, me and Mini made a small realization now that we two are the only people on stage who are not the young, Mini is 1 year senior to me in Trivandrum. So we are in the next generation of ophthalmologists. It's very heartening. It's very, very heartening to note that the young brigade of ophthalmologists in Kerala are coming up so well. They're very good at presentations. They're very good at organization. They're very good at communication. We never had these sort of opportunities when I was a PG or when I was a medical student. And looking at the online resources that are available, it is tremendous. I mean, the way knowledge is being dissipated, what access you have to knowledge, to surgical videos, to YouTube. Even this program is now YouTube live. Am I right, Rajiv? This is now going live on YouTube. So technology is being used in a tremendous manner, and I'm really happy as president of the KSOS that this is happening. And in many ways, this CM is very unique because I had announced when I took over as president in Kozhikode last November that I would like to have a program conducted by the young brigade of KSOS. Actually, there is an association called YOSI, which is a Young Ophthalmology Society of India. So I actually said there should be a Young Ophthalmology Society of Kerala. I would rather like to read K as Kerala and not as Kollam for the YOLK, although it is being conducted by YOLK. So I would like to mention to it as the Young Ophthalmologists Brigade of Kerala. And thank you, Kollam, for taking this project as this is my pet project, a presidential project. And thank you, Kollam, for taking it up. And whoever are involved here, I mean, we all know that one person's brain is behind this always, and that is Rajiv. So my special thanks to Rajiv for making this happen. He has been the fulcrum around which the Kollam Ophthalmic Association has evolved and worked over the past many years. And I was telling Rajiv today morning that hopefully in this venue, in this place, you will become president of the KSOS. I am predicting this. You will know whether it is right or not in a few months' time, but this is what is actually going to happen. So best wishes to Rajiv and everyone in the Kollam Ophthalmic Society. We have had two very interesting sessions. How to prepare for postgraduate, for the exams. And I'm really, surprised at the amount of material the postgraduate students are getting now. I don't want to compare with what we had. It's obviously out of comparison. But, the amount of quiz programs, almost every CME program has a quiz. Almost a lot of CME programs have OSCE for the benefit of postgraduates. So you just have to put in some effort, to make sure that you come up with really flying colors in your future. And so much fellowship opportunities, so many new hospitals coming up. So it's a bright future. It's a very good specialty to be in. And I'm proud to be the president of this society. My term, of course, ends this November in the Drishti conference of Thrissur. And I once again thank the Kollam Ophthalmic Association for taking up this presidential project. And I'm sure that all of you will benefit from this program. And especially, I haven't met Dr. Divya before, although we have observed what all work she is doing for the community, for the society. And it was a real pleasure meeting Madam today. So that is another special event that has occurred today. Thank you very much, and I wish this program all the best. And I'm sure the coming two programs and the quiz will be as good and as interesting as what has happened today. Thank you very much.
Thank you so much, sir. Now I request the organizing secretary, Dr. Divya Kishan, to introduce our chief guest.
Dr. Divya S. Iyer, District Collector Pathanamthitta, actually requires no introduction. She has been in the forefront of Kerala's administrative and cultural arena for the last couple of years. A native of Trivandrum, she completed her medical graduation from CMC Vellore. She joined IAS in 2014 and had her first posting as Assistant Collector at Kottayam and then became the Sub-Collector of Trivandrum. She worked as a Nodal Officer of Systematic Voter Education and Electoral Participation in 2016. She was also the Mission Director of Mahatma Gandhi National Rural Employment Guarantee Scheme. She is the District Collector of Pathanamthitta since July 2021. Her illustrious career is backed by her voracious reading, passionate writing and singing. She has authored a book for the IAS aspirants, Pathfinder. She has edited the book Applied Diplomacy Through the Prism of Mythology and has authored Ethrayum Priyapettavalkku Oru Feminist Manifesto. In 2016, she also wrote and sang the song Viral Thumbal Nammude Bhavi to promote awareness of voting rights and to encourage voting. To add icing to the cake, she has acted in the Malayalam movie Eliyammachiyude Aadyathe Christmas in 2017. She is an epitome of versatility and has carved her niche as the true youth icon of Kerala. We are proud and happy to have you here, madam. Now may I request our chief guest to inaugurate our CME by lighting the lamp and then deliver the inaugural address.
it's my pleasure to welcome our chief guest, Dr. Divya S. Iyer, IAS, for the inaugural address.
Dr. Sai, Dr. Mini, Dr. Divya, Dr. Vishnu, all the wonderful ophthalmologists from across the state on and off the dais. A very warm good morning to one and all. It indeed gives me great joy and pleasure to be amidst you all this wonderful morning for two reasons. One, when I get back to being in the midst of doctors, it always feels like homecoming to me. I think a couple of weeks back, I was in RCC for another CME, and I reckon uttering the same words there. And it always comes from the heart. It's rewinding a decade in your life and doing a time travel is not an opportunity that comes by every day. So the moment I stepped in here, or rather the moment Dr. Vishnu and others had come to meet me, the first thing that came to my mind was all the wonderful ophthalmologists whom I have met in my life in CMC, Vellore, and our training there in the Shell Eye Hospital. And every single day and every single examination, which has actually led to spreading light in the lives of several hundreds and thousands of people across the country. I want to dedicate this day in memory of all the patients who had actually come to our eye hospital in Vellore while I spend my time there, for the sheer grit and determination that each one of them possessed, despite the suffering that they had gone through. The stories that I've heard from them, I think has really stuck to me forever, that it continues to inspire me in every profession and in every mission that I take upon in my life. That was a phase of my life which actually proved to me the words of the famous writer and inspirer, I would say, Helen Keller, who said that the world is full of suffering, but it is also so full of overcoming it. And how beautiful is that thought, that the world is full of suffering and it's also so full of overcoming it. As we all know, Helen Keller and her teacher Annie Sullivan were two people who literally lived it out in front of our own eyes. And every time I would meet somebody in the Shell Eye Hospital, I would be instantly reminded of these words. I don't know why particularly, the patients whom I met in the ophthalmic hospital reminded me of this. Probably also because of the fact that there is so much that we rely upon the eye and the vision for our daily living. And the world is structured in such a way that living without the vision and the sight becomes incredibly difficult. And hence the suffering as well as the overcoming of the same also becomes equally difficult, I suppose. And the joy and pleasure that a patient and his or her family actually goes through when you regain the sight is one of its kind. That's, I'm sure each one of you keep experiencing it day in and day out. And there is no better blessing than that, to be a witness to that, and also to be the reason for that. And I heartily congratulate and offer my pranams in front of each one of you to be, to be working so sincerely day in and day out, to be reasons of spreading light in people's lives. I remember this incident in my life during my training period, wherein as part of our training in Hyderabad from the academy, we were actually taken to this hotel. I've narrated this incident a couple of times before. I don't know if any of you have been there. So all of us were taken to this restaurant. We were just told that you would be taken for a dinner out in a mall. And that's a very unusual proposition during your training life, right? So all of us are officers who are under training, and we said, wow, okay, taking us to a mall, that's a great deal. And yes. And so we decided that all of us would go to the mall, and we were asked to go in front of the restaurant, and once we reached there, we were asked to deposit any light emitting device with us or any sound emitting device with us at the counter, which meant that our cell phones and our watches or any other alarm making device or light emitting device would be deposited at the counter. So we were in two minds, but still, since it was a strict instruction, we complied by it. We deposited all of them and we entered the space. And we were told that the restaurant is called Dialogue in the Dark. And I can see a lot of heads nodding out there. So I'm sure that many of you would have gone there. If not, I think every student of ophthalmology definitely should go through it. I would say every person, every single person on this earth should go through it. But if that is not possible, at least every student of ophthalmology should go through it. So once we stepped into that dialogue in the dark, we were 5 in a group. We were handed over the aiding sticks in hand for our maneuvering around in the dark. Friends at that point of time, we were just acquaintances. We just knew each other by name probably and not really more. But once we stepped into the dark, something so miraculous happened. We just completely started trusting each other. That was the most important lesson that I got from there. We were dark. We were in the dark. We didn't know where we were. We didn't know where to go. We didn't know which direction to go. And all 5 of us in the group just held our hands together and we completely started trusting each other. That was the first response that the human nature actually, gifted us with. And it's not unique to us, but it's a part of human nature, and it happens every time we are in a crisis. And we see that day in and day out when we are stuck with crisis, when we are faced with crisis. And once that happened, we had one person who was assisting us throughout this journey inside. So he introduced himself to us. I remember his name was Mr. Venkatesh. So Venkatesh said that, he's a staff in the hotel and he would take us through this fascinating journey in the hotel, and at the end of which we would be served food as well. So the first point where we stepped into was this place where, we could hear lovely sweet sounds of birds and waterfalls and some rustling of leaves. And so, just with the voice, just with the sounds around us, just with the ambient noises and sounds around us, Venkatesh asked us, can you figure out, what kind of an environment are you in now? And boom, immediately we all knew, we were in front of a waterfall, so, we could actually stand there and experience the water, falling on our feet without actually seeing it. And soon after that, there were some fragrances that was emanating from that space. And then, we were asked to identify and appreciate the fragrances and the odor in the ambient surroundings. And soon after that, he said, now let's do some shopping. You've had some experience, some nature's gifts out there, so now let's do some shopping.
And we were taken to this place where there were multiple shelves. And, obviously we didn't know whether it were benches, whether it were shelves, whether it was vegetables, whether it were groceries, what shopping are we going for, whether it's stationery. So finally, I think I picked a potato. And trying to identify the vegetables just by the tactile feel of it and probably the smell of it, and trying to pick some stationery from there and all of that. So we were asked to pick a few items specifically. So once we did that, he said, now let's hop onto a boat. So, we had sounds, we had fragrances, we had tactile stimulus. Then after that, he said, let's hop onto a boat. Now we became a little, unsettled. Without seeing, how does one, get onto a boat or hop onto a boat and keep sailing? Otherwise, we were on flat ground, we were on the earth, we had the sticks with us, so we knew where we were treading, at least till that point of time. So, now it was a bit of, ruffled feathers around us there. And he said, I'll help you. You can hold on to me and you can hop onto the boat. So, there were ropes and there were chains probably by the side of that water body inside. And I remember us hopping onto the boat with heavy hearts. And once we hopped onto the boats, we sailed for a little while, carefully rowing so that we don't topple the boat over. And once that was over, we were a bit exhausted, to be very honest. Though we enjoyed the whole process, though it was adventurous enough, but the exhaustion of adventure had actually set in, We said, okay, now that's it. And finally, he said, okay, now that you're tired, I think we can go and have some food. So we went to the restaurant and, we ordered some food. And he said, you have to go to the counter and pick it up yourself. Now, going to the counter in the dark, trying to pick up the French fries that you ordered, making sure that the food is veg and not non-veg, especially for me. But the more difficult part of it was the payment that was to be made. So, just with the feel of the currency notes, one had to figure out if it was a 50 rupee or a 100 rupee or a 500 rupee note, and you had to hand it over and then get the bill and the balance back. And honestly, none of us knew how much we paid that day. So, and but it was truly the most amazing and the most remarkable experience in my life. The entire experience took around 45 minutes, I think. And just to mark the end of it, we made sure that all of us had a group huddled together, the 5 of us in the team and Venkatesh, and we sang a song together and made sure that all of us leave that place with memories that would never be erased. And the most important revelation, I would say, came after that. When we stepped out, all of us were, as I mentioned, it was adventurous, it was thrilling, but, we were happy that we were done with it. So the moment we stepped out, we said, thank you so much, Venkatesh, for leading us through. This is one, lifetime memory that we would all cherish with us. And we said, can we take a picture with you, Venkatesh? So we had to get out and then take our phones and then take a picture, right? So he initially, was hesitating a bit to step out with us. And then he told me, thank you all for coming along, but this is how I live my life every day. Venkatesh was a visually challenged person himself. And, that moment changed it all for us. Till that point of time, it was just an adventure for us, and we were very grateful that, after 45 minutes of being in the dark and trying to live in the dark, we've returned to our normal lives. And, I remember all of us, I don't remember any other time when, all of us just burst into tears at the same time, because the experience was so intense. And he gave us no clue about this throughout that journey. It was only at the end of it when we requested whether we could take a picture. That's when he stepped out of the dark and he actually revealed himself to us and told us that this is his life's experience, this is his daily life that he's sharing with us, and it's not just him, but several people like him. And the positive, or the silver lining to it was also that Venkatesh was a highly positive and inspiring person who actually taught us that, even without sight, when you can appreciate the fragrances and the sounds and the tactile stimuli, and every other sensation that wraps you around in this world, you can still live a full life, full of thrilling experiences, full of enchanting experiences. And that is the most beautiful part of that experience which I would like to carry. Even if we tend to go through suffering, the art of overcoming it can be woven in such a beautiful manner that life can still be full of enchanting experiences. And that's what Venkatesh taught us. I, tried to stay in touch with him for a few months, years after that, and then I realized that, he's gone for doing his post-graduation and in the National Academy of Visually Challenged. And, I hope that Venkatesh and his ilk, all of them continue to live their lives spreading light in others' lives as generously and as abundantly as he did in our lives. So, that's one experience I really wanted to share with you all, because being able to live the other person's life, when a patient comes in front of us, when we can actually live their own lives and experience what they are experiencing, that's when we become healers and not merely doctors. And I hope and pray that each one of you are healers to everyone who comes in front of you. My little son Malhar is here now, and that's something that I have learned from him too, because he's very fond of percussion usually. So, albeit now he's a little sleepy, but he's very fond of percussion usually. Aricheshi knows that. I'm sure she has, seen a lot of videos of him. So, every time he picks up the chenda or, the tabla or whatever toy percussion that he has in his hand, the first thing that he does is he claims to be the chenda mama himself, And it's only after that he starts playing it, He just turns into that person. And he is no longer Malhar or Mahi Baby that he is. Once he takes up that role, he instantly becomes the chenda player. And, that's, only after that does he actually start his, drumming or his percussion work. And once he's out of that, then he becomes Mahi Baby again. And, it's not something unique to him again. I think all children do that, The pretend play that children do in their childhood is, to me, it is much beyond just a play. Because as children, all of us very naturally want to be in other people's shoes as well. We want to feel how other people feel. We want to be other people at various points of times in our lives as children. But as we grow up, our identity and our sense of self-esteem takes over so strongly that sometimes we leave behind empathy and compassion, in a struggle to actually keep up our self-esteem and our identity. To be able to let ourselves loose a little bit and become the people in front of us, albeit for a few moments, I think will definitely make a huge difference in the lives of both the giver and the taker, because it's a sharing process. It's not only for the person in front of us, but when we decide to look at someone with the kind of empathy that children naturally look at each other, I think that's when we become better people day after day. And this is something which, I try to practice in my life every day. So I just thought I should share it with you all. And once again, let me place on record my heartiest congratulations and pride in being associated with this highly vibrant and energetic team, YOLK Insight, wherein each one of you are healers by yourself, spreading light in lives of people who come by you. And I pray that may thousands of people be inspired by the good work that you do day in and day out. And may you continue to strengthen each other through such meetings and through such sessions, so that you carry back the empathy and the grit to actually cater to those in need around you. When we leave our alma mater in CMC, there is a graduation song that's played for us usually. It's called Carry Your Candle, and I think that's something that I carry with myself everywhere I go. And I want to leave you with that thought that, each one of you would carry your candle wherever you go, spreading light in darkness and making sure that the lives lit by you all continue to light several lives further on. So thank you so much again, for this wonderful time. And I wish you a hearty day, full of smiles, full of light, and full of empowerment. Thank you so much. My special love to Sasanama Mama also. Happy to meet him here. Thank you.
I'm sure that this interaction with our chief guest was a valuable learning experience for all of us. Thank you so much, ma'am, for those inspiring words. And special thanks to Mahi Baby for joining us. Now may I request the KOA President, Dr. Mini Jayachandran, to hand over a small token of appreciation to Dr. Divya, ma'am.
Thank you, ma'am. May I request the organizing chairman, YOLK Insight, Dr. Divya Kishan, to hand over a memento to Dr. Sai Kumar, sir. Thank you, ma'am.
I invite the KOA Secretary, Dr. Shiny Napoleon, for the felicitation speech.
A very good morning to one and all. Respected KOA President Dr. Mini Jayachandran, Chief Guest Dr. Divya S. Iyer IAS, Guest of Honor and KSOS President Dr. S.J. Sai Kumar, Organizing Chairman Dr. Divya Kishan, Organizing Secretary Dr. Rakhi P. Cruz, respected teachers, seniors, friends, and YOLK team. It is an honor for me today to stand here as the Secretary of Kollam Ophthalmic Association. Today, we are conducting a new CME, YOLK Insight, a presidential program, first of its kind in our state, with full participation by youth for promoting them. Dr. Mini Jayachandran, KOA President, and Nightingale of KSOS, put a great effort in planning and execution of the CME. We are really honored by the presence of Guest of Honor, Dr. S.J. Sai Kumar. Sir will be very happy to see the implementation of his program. Another privilege we got today is the presence of most talented, charismatic, gorgeous chief guest, Dr. Divya S. Iyer, as a youth icon. Madam happily accepted our invitation and graced this occasion by her presence. Madam's presence made a completeness for this program. A very special personality in KOA, the one and only Dr. Rajiv Sugumaran, who is an asset to KOA as well as KSOS, took the initiative for the CME, suggested the name YOLK, selected the theme color, and gave all guidance to the CME along with Dr. Jayasri Rajiv. We conducted 3 executive committee meetings and handed over the program to our youth. Our senior members, Dr. Jayaprasad B., Dr. Uma Mohandas, Dr. Rameshan, and our president, Dr. Mini Jayachandran, gave all guidance. Young ophthalmic leaders of Kollam took over the entire program under the guidance of most energetic, brilliant, and enthusiastic organizing chairman, Dr. Divya Kishan, and the all-rounder, charming organizing secretary, Dr. Akipi De Cruz, and our treasurer, Dr. Vishnu Mohan. They beautifully planned, organized, and executed the whole program in a systematic manner. This CME is a hard work of this young team. Conducting a quiz and preparing questions is a big task. Special congratulations to Dr. Anjana, Dr. Jubeira, and Dr. Lakshmi. Each one of them put their own effort for the smooth conduct of the CME. A big hand of applause to them. On behalf of KOA, I wholeheartedly appreciate our young team, and they have proved that Kollam Ophthalmic Association is safe in their hands. All the very best to our young leaders and also to the CME YOLK Insight. Thank you.
Thank you, ma'am. Now I invite the Organizing Secretary, YOLK Insight, Dr. Rakhi De Cruz, for vote of thanks.
A warm good morning, one and all, and it's my proud privilege today to host you all in the land of Ashtabudi and to propose the vote of thanks for today. At first, I would like to thank the Lord Almighty for making this CMA happen. Next, I would like to thank our respected KOA President, the lady with a beautiful heart and a motherly warmth, Dr. Mini Jayachandran, for giving us this opportunity to conduct this CME. I would also like to extend my sincere gratitude to our tall and mighty KSOS President, Dr. Sai Kumar sir, who has come all the way here to support our young hearts. I hope we have not disappointed you, sir. Thank you, sir, once again. I would like to extend my sincere thanks to our chief guest for today, Dr. Divya S. Iyer. When we went there to invite her for this CME at the Pathanamthitta Collectorate, we understood how tightly packed her schedule is, and none of us are actually as busy as her. And the only day she gets off is this precious Sunday. So when we requested her, it was humbling that she obliged to come here, and that too on this precious Sunday. And the only request she made that she will carry her kid along because it was her only day with her kid. Thanks once again to Dr. Divya. Next, I would also like to extend my sincere thanks to our Chinese Napoleon Madam and also Dr. Vishnu Mohan, our organizing secretary and chairman, who helped us throughout this CME. And I'll fail my duty if I don't mention about the manpower and the master brain behind this YOLK CME. So this idea of YOLK was born during a casual talk between me and Rajiv sir during the last AAOS. When we suggested forming a young forum at Kollam, the very moment he became very excited, and then and there itself he named it as YOLK. And within few weeks, JP sir and Rajiv sir called for an executive meeting with Shiny Madam, Mini Madam, and everybody. And they appointed us, me and Divya Chichi, as the organizing secretary and chairman, and asked us to come up with a list of suggestions of topics and also to suggest speakers within 5 days' time. So they were actually testing us. But during the next meeting, when we came up with the topics, they were so supportive and they guided us throughout and asked us to make a WhatsApp group including all the young KOA members. Kollam being a small club, we thought we'll hardly get around 10 people. But even to our surprise, we had nearly 25 young and enthusiastic ophthalmologists from Kollam who were very enthusiastic throughout, and every one of them did a remarkable job in the committee they were put in. So we divided them into all the committees like in a normal CME, travel accommodation, registration, everything was there. Each one of them did really well. Special mention should be made to the registration committee because they made such a huge audience possible, and also the quiz committee because they had novel and innovative ideas which is coming up. Next, I would like to thank a special thanks to Mr. Vivek, the Sivira manager, who has helped us with the quiz, also the travel facilities also. And other pharma companies like Cipla, Endot, Sun Pharma, Sunways, Micro, Rhine, Ostrec, Mankind, all of them has helped us in this CME. I would also like to thank the hotel staff here and also the audiovisual team headed by Naufel for the smooth conduct of this CME. I would also like to thank all the chairperson, moderators, and all the faculties who came here accepting our invitation and for making this possible. Last but not the least, for all the delegates, our senior KOI members who came all the way here to show their support to us, and all the postgraduates, my teachers, and my friends. Thank you all once again. Now, I would like to request you all, especially Dr. Sai sir, for the surprise cake cutting we have here. Please gather.
Now, let us move on to session 3. A career in ophthalmology is a demanding profession and requires aspirants to stay up to date with new researches, upgrade their knowledge and skills, and read a lot of journals and papers. But when developing your career, it is important to take time for both your professional goals and your personal life. As Hillary Clinton said, don't confuse having a career with having a life. So to erase all the confusions, we have session 3, Beyond Ophthalmology.
Let me invite the panel. The chairperson, Dr. Marine Paul, Medical Director at Trinity Eye Hospital, Thrissur. She has special interest in cataract and phacoemulsification. She is active in state and national ophthalmic societies. Hearty welcome, ma'am.
Let me welcome the co-chairman, Dr. Latika Vasudevan. She is professor and head of the department at Amala Institute of Medical Sciences, Thrissur. Areas of interest being cataract, medical retina, and retinopathy of prematurity. She has many presentations and publications to her account. Welcome, ma'am.
Now inviting the moderator, Dr. Anita Prabhakaran, Senior Consultant at Precise Speciality Eye Care, Trivandrum, with special interest in pediatric ophthalmology. She is passionate about classical dance and music, also very much interested in acting, gardening, cooking, teaching, and mural painting. We welcome you, ma'am. Now I hand over the session to Dr. Marine Paul, ma'am.
So good afternoon everyone, and thank you KOA for having us here. It is indeed a wonderful session, as we can see that the youngsters are really holding the flag up high. And today we also have a session with a difference, that is life beyond ophthalmology. And I think the best icon for that was Dr. Divya, who came, IAS, who came all the way. And I think she has shown us, by her speech and her actions, that being a woman, being, a mother does not really stop you from achieving things. And this, I think, is an important message, especially for ophthalmologists, because we are a woman-dominated field, and a lot of us do, have hesitations about following our passions, following our dreams, because of the fact that we are women. And of course, even for the few men who are here in ophthalmology, this session is going to be a game changer for all of you, because it will show you that life does exist beyond ophthalmology. So without further ado, our first speaker will be Dr. Shweta. Yeah. No, that's okay, anything. So I would request Dr. Anita to introduce our first speaker for the day.
Let me call upon Dr. Shweta, who has done her medical graduation from Calicut Medical College, and from Coimbatore she has done her post-graduation and done a fellowship in glaucoma in Satyan Eye Care Hospital in Coimbatore. She is currently a glaucoma and phaco surgeon at Jyotis Eye Care and has been an orator and a co-instructor in many courses, and has been an invited faculty speaker as well. So it's mentioned that she's keen on enhancing patient and public awareness on eye health using advanced multimedia platforms. And she is going to talk us a little bit about work-life balance. And according to the Zen, it says that life balance doesn't come naturally, or nobody gives it to you. You have to create it yourself. So let's hear those valuable words from her.
Thank you, madam. Warm good morning all. Now let's go something beyond ophthalmology, finding the right balance between professional and personal life. Rather than calling it a work-life balance, I would take the term work-life integration, because our career is just a part of our life, along with our home, family, health and well-being and community. We have to take all together. We have to blend it and move forward. So I'm just giving you few tips. Remember that everyone has their own idea of the work-life balance. So it is a process and it will take time. So first and foremost, what you have to do is to pause. You have to pause whichever stage you are and then evaluate yourself. Evaluate, and you have to ask questions like, am I really doing what I want? Do I give enough time to people or things meaningful to me? Did I achieve my professional or personal goals, and where do I feel the most struck? Once you start asking these questions to yourself, then you'll know what exactly you want, what adjustments you want to do. Now, life will never change if you're waiting for the future. We think that next time, after this, we are going to get better. But be proactive, do the change whatever you want to do. Once you analyze, you have to set your priorities. Neglecting self-care is the main thing that happens now. We see lots of mood variations, depression, we call it midlife crisis, and it leads to divorces, suicides. We hear a lot of them. So the first thing is you have to put your family first wherever it is. We doctors say that we put our family first, but when you take day-to-day basis, is it really true? We have to see. And putting the family first means spending quality time with them. Children usually, what they say is, my son, he generally wants me to play with him like what they play. Only then they say that we love them, not by what we buy for them. And next is finding your dream job. So as rightly pointed out in previous session, you have to set your foundation when you're younger. Do whatever you want, because young is a time when you have lots of energy. Do the studies after completing post-graduation, do the fellowship, and take all the degrees, whatever you want. Set the foundation very strong that next stage of life you'll be more settled and you'll have more balance. And once you have to find your job, find the right fit in. You have to see whether that job is really meant to you. Research thoroughly and then go and join. Just not for any salary, because after 1 year you're going to leave that job. So it is always better stick on to one place and try to grow from there. And setting boundaries is one important thing that you have to have. Once you're into the work, forget everything else, fully put you in your mind and work into the work. And whatever free time you get, do the research. Research is one area where you can always update yourself and be active. And but always make sure you have to say no whenever you're getting overworked. So once you leave the work and come back to your family, make sure that you're putting your full effort into the family. Don't take any work into the family. But this is always better said than done. You all know how much difficult it is. And occasionally we feel burnout. Burnout is an occupational phenomenon where whenever you have this burnout, just take your time out, unplug yourself. When you have any friends, just go out, chill yourself. I have these wonderful ladies in my life who are my batchmates. We go out, it's kind of really refreshing to go have a break and then come back with lots of ideas. Next is the time management. We know it's all difficult in this situation, how much time goes in these, whatever I've shown it. And one thing what you can do is, in your iPhone as well as Android, you have screen time option. If you look at the screen time, how much of your time you're spending in each of these apps, you can see. And you can also set downtime if you wish. If you wish not to get distracted during your work, you can set it daily. Once you're with your family, you can set that time as you're not going to use it. You can see this, it will show that you have reached the limit of that particular app. But always you can cheat, but still if you keep something like this, it gives a little bit of control over yourself. But technology, you can use it in whatever Dr. John has shown, for those things you can use the technology. And Android has a digital well-being. Now always find a schedule for yourself for the day. Make it a realistic one and not a perfect schedule. And finding time for other things that you love professionally. I love to present, so just squeeze in time for having some presentations like this. And it is also important that you have family time. Taking a vacation, going out, once a year you have to take a big vacation. And reclaim your passions is one thing. I love to dance. So these are the programs which I've done last 1 year. You can see this is from the July to this July. These many programs I've done. It actually, and these are from the Kollam Ophthalmic Society. We have a good group of doctors, ophthalmologists. And also, I am not an artist. this I have done only when I feel low. Whenever I feel depressed, if I draw one picture out of it, it's kind of, it has a meditating effect. You get really refreshed and you come back. So find out whatever you have within yourself, bring out that passion. It's never late, because the people who are dancing with me, they are in their 30s, 40s and 50s. You won't believe above 50, they have so much energy to come and do all this. And always prioritize your health, do some kind of exercises. And this is me. I have lost 13 kgs in 7 months. The thing is, I just want to say, just stay motivated. Nothing is impossible. And take time for personal reflection. Just 5 to 10 minutes daily is sufficient. If you sit simply, do some meditation, do some motivational reading, just 5 to 10 minutes of your time daily. Keep a journal. That will actually help. And the final quote for today is, love what you do and do what you love. That is the most important. Thank you, and thank you, Kollam Ophthalmic Society, for giving this opportunity.
Thank you, Shweta, for that. Really, you've packed a lot into that small time that was given to you. But like she said, I think the most important takeaway here is that it is about choices, the choices that you can make. And yes, Latika, what would you like to add to that?
Yeah, Shweta has really elaborated some of the tips that she found useful. But when it comes to balance, it is actually the mantras are thoroughly individualistic. So when we say balance, we should also know that when we balance two things, we are also at risk of compromising both. So when we have only one thing to do, our focus is entirely on that. And naturally, we tend to get more perfection out of it. Whenever we balance two things, always there is an element of compromise in it. So whether we like it or not, this will happen all the time. So that does not matter. And there is the thing that I found, Shweta was saying that when you do something, you have to focus on it. Yes, that is true. But stretching it a bit more further, it helps very much. What has helped me to find a balance without too much of a compromise, I hope, is that I have divided, I set goals only for 5 years. So every 5, because this concept of balance itself is shifting. What we are 5 years from now, what I am 5 years from now is not what I was 5 years before. And my concept of balance also changes with me. So what happens is, in the 5 years, whatever you are, you understand yourself first and you set your balance accordingly. And in 5 years, I might put my family as the first priority. In the next 5 years, I might do academics as the first priority. So it always helps if you can do that. It might, it is each one to himself, but this is something which has helped me a lot. So, one more thing I wanted to say was about this, yes, I think I've forgotten it now. She was, so I think I'll hand it over to Anita.
That's very true what Dr. Latika said, that it's always a compromise. But still, one point I would emphasize here is that in order to not to compromise, it's always also not good to concentrate only on one thing and ignore the other one. So it's like just like as she said, it's a balance is like a bicycle and you need to keep moving. And of that, do not ignore completely, take everything hand in hand, side by side, but at the same time, prioritize something at one time so that you can achieve perfection in that. At the same time, not to completely ignore the other part as well. So shall we move on to the next talk? I'll hand over the mic to Dr. Merin to introduce the next speaker.
So our next speaker for the day is Dr. Prithvi Chandrakant. He is a medical officer with the Department of Veterinary Services at Aravind Eye Hospital, Coimbatore. He was. And he is known in our KSOS circles and in the national circle as an innovator, and he comes out with very, very interesting videos. And he has won multiple awards, which you can see. So over to you, Dr. Prithvi.
Good afternoon, all. Thank you, ma'am, for that introduction, and thank you, YOLK, and Dr. Rajiv, sir, and Dr. Raki for having me here. I'll be talking on how we can make videos and edit videos, not just surgical, but the whole videos, how you can animate also. Just a small glitch. So before it gets loaded, I'll be talking just about how I do my video presentation. It's 10 concepts, 10 steps which I'll be going through now, and each step singly, and then put together. I'll show you a few examples on how it works all together. For the beginning, we need a concept. So the concept, if you have a good video concept in the sense you have introduction, what the problem is, or what is the gist of what you want to talk, and then telling them what you have done, or in surgical grounds or medically, and then showing them the results. So that should be a proper concept on what you want to present. So according to that, you can make the video. So be pro at video making and editing. So 10 steps and 10 concepts on how we do it. So the first step is always the topic and the script. So you need to have a very good topic with different introduction, aim, purpose, the result, and what the material, method, or the surgical steps you are involved in. The second step is having software. So you don't need big softwares. You just need PowerPoint, Keynote, which is almost the same thing, like a PowerPoint presentation in MacBook. And then that is the most 80% of the video is made in the PowerPoint and Apple Keynote. And only the trimming part and the slow motion or the fast, we do it with the Apple iMovies or any other free video editing softwares. So 80% is the PowerPoint and 20% is the iMovies or any other PowerPoint video editing software. You can also download, the third step is downloading templates which look very good. It's free of cost for the PowerPoint and for the keynotes. And you can have like these kind of slides. You can see how there are some comical style infographics, a Halloween theme. So you can set one theme and go along with that with the concepts. And to increase the attractivity, to make it more attractive, you can use different fonts. So you can take the fonts which go with your theme, but be very sure that it is legible. So the fourth concept is using fonts. The fifth concept is using images. It could be still images or GIF images, where you can see, you can make a complication. You can put a GIF image like this, and when you manage it, you can put like a GIF of giving a toast. And when you use still images, there is an option of removing the background, and you can remove the background. It has to be a contrast. So once the contrast is, you can remove the background and use the picture. So this you can do with any picture. Trimming can also be used. And finally, I'll show you how it looks. So this is sixth step is choosing music. So music should be copyright free, and it should go with your theme, and it should not be very loud when you present, when you talk. It should not hamper your talk. And then you have animation effects. These are one of the most underrated things. You have animation, like what you saw now. We can even put a nucleus and it falling down to the vitreous, so something like that. You can make your own animation with PowerPoint and Keynote. There are a lot of other animation effects which you can use and which we can depict in our videos. And then we have transition from slide to slide. So you can see over here 41st and the 42nd slide, how I'll make an object. This is the object which is there, which I copy, and in the 42nd slide, I put in another side. So over here, I'll be using a transition called the morph or the magic move. So once you do that, you can see how it moves from one side to the other in the 41st and 42nd slide. Again, I'll show you. See, just after you put the magic move, how it will slowly move from one slide to the other, removing. So I'll show you how it works. So this is editing shapes. So ninth thing is to edit shapes. You can change. You can use this step to make your own animation of whatever surgical technique you want. Like I'll be showing you how a nucleus and cataract step is done eventually. The 10th step is, like I said, the 20% of the whole video editing is done in the movie editor, the video editor. So there are a lot of free apps in the internet. These are all the names of the free apps. So this one is actually used only to cut, trim, and move it fast, slow, all those kind of features. Over here you can see I'm using iMovies. Almost all the applications are similar to this. So you put the video, once you put the video, remove the audio, because sometimes we don't require the audio which is there. Remove the audio, and then you can even add the music which we have downloaded from the internet without copyright. And then you select a place where you want to split the clip. So that is the clip which you want, and now you made it 2 segments and now 3. The middle segment was not required, so we deleted it. That is as simple as that. So movie editing is very easy. You just have to split the video into segments and remove the segments which you don't want, and whichever is there, and then finally just regroup it, or it will merge into one particular video. Over here you can see how you can make it fast and slow. So this is how we made it slow, how we can make it fast, double speed or 4 times, and then this is a trim. So you can trim the video into whatever you want. So this is a very simple process, and few examples. Like over here you can see a fundus image which has been morphed using magic move, and how beautifully it enlarged. And then how you can show the macula, and then you can even put the annotations. The same way over here you can show the OCT, and how these line draw which I showed you can be used to mark each and every signs and make it more clear to your audience what you want to actually depict in that OCT. Many of the times when we see there is just a OCT and the person is just talking, you don't know which is what sign. So over here you can see how beautifully you can actually design the whole OCT to understand what is and how it is, what is the signs. Where you can see this is a GIF image which have been put. So that will be going on. And then this is the image with background removed, the fonts, and the magic move or the morph effect which has made the whole video. You can see how you can depict what you want to depict of how ROP screening is done. And this is all done by just the PowerPoint. This is how you can see over here how a pupil is dilated, the incision is made, and the tunnel incision, how it is going inside and wriggling. So you can actually make it very easily. This I made just 10 minutes from here. So it is very simple. You just need the normal Microsoft PowerPoint and a free video editor to do all these things. Thank you.
Thank you, Dr. Prithvi. That was really very eye-opening, especially probably not for the youngsters here, but at least for the seniors, because video editing and all these are like areas which, especially like, ophthalmology especially, I think we need to have these skills these days. It is, because all presentations require videos, and it is very, very important that you have some amount of idea about how to do about this. I think we should have a full CME on this.
We should have a workshop.
Workshop on, yes. Yeah. So, in the interest of time, our next speaker is Dr. Arya. I will ask Dr. Anita to introduce, Dr. Latika to introduce Dr. Arya.
Okay, I'm really, really privileged to introduce the real star among ophthalmologists and the ophthalmologist among stars, Dr. Arya. So she's by designation Assistant Professor RIO Trivandrum, completed her entire medical education including MS from Trivandrum Medical College and RIO. She has won Kalatilagam in the School Youth Festival, not once, not twice, not thrice, but 4 times. And again, she did it again in the university level, in the College Youth Festival also. And she, as we are all aware, she was an anchor in many TV shows and a familiar face to all Malayalis, not just ophthalmologists. Acted in movies, Padigam, Butterflies, all blockbusters of the time. And latest Even now, she has acted in a movie Vashi recently as 2022. So, and her passion, abiding passion is dancing, which she continues. So, over to you, Dr. Alia.
Thank you, Latika Madam, for those kind words. At the outset, let me thank the Kollam Ophthalmic Association and the organizers, especially Dr. Divya Kishan, one of my dear ones, who gave me this opportunity. As a teacher, I am happy to participate in a CME in which one of the organizers is my student, Dr. Rakhi Dikros. So moving on to my presentation, pursuing passion with profession. So what is passion? If you search for the meaning in dictionary, it will be like, it is an intense feeling of enthusiasm that you get when you do something. So what are the fields of passion? Anything under the sun can be passion. So one of my friend's husband, he's a very busy practitioner, a gynecologist, and whenever he gets time, his passion is bird watching. So whenever he gets time, he takes a break from his busy schedule. He goes to the areas like Tekadi, goes into deep forest and spend hours and hours bird watching. So when I told this to one of my colleagues, her first response was, bird watching, what does it mean? So passion to one person may sound awkward or a little bit cracky to some other person. So it can be sports and fitness, music, dance, designing, gardening, cooking, anything. So what is harmonious passion? As Dr. Shweta told, when you're able to balance your profession with passion, it goes hand in hand like your harmonious ARC. So find out time to spend for your passion, not affecting your family members. As she told, we all have family, we play different roles like daughter, son, brother, everything. So it's not like your passion should become an obsession. You should spend so much time for your passion, not looking after your family members or your daily routine work. So find out time to spend for your passion, not like every day this much hours I'll do dancing or I'll spend time for music, singing, etc. Find some time, barely around 3 or 4 hours per week, something like that. So when your passion is harmonious with your profession, it will give you psychological benefits. It can be a source of income as well. You develop new skills, you build up your self-confidence, and you'll be able to concentrate more on your work also. So this, as all of you know, this is Dr. Charles Kellman, the father of phacoemulsification. So there was a beautiful journal in our own KJO written by our dear Biju sir, who is my beloved teacher also. You should go back and read it. So Dr. Charles Kellman, he was an ardent fan of music, and he wanted to become a musician. But like any other Mallu father, his father also wanted him to become a doctor by profession, and he was forced into the profession. He studied, he took ophthalmology, thinking that he can spend some time for his music also. Everything is beautifully written in that journal. I don't know to present it that beautifully as sir has written. So finally, he achieved everything in ophthalmology. He became the best ophthalmologist of the century also. But he might have felt some sort of restlessness that he again started pursuing music lessons. And finally, he performed he was a saxophone player, so he performed that in a stage, and he shared the stage with a lot of jazz musicians. So, might be at that time, he should have got a feeling of completeness. So how to find out passion? It's not like you go behind passion and find it out. There was a Tamil movie directed by Gautam Vasudevan. In that, the hero and heroine separates due to some reason, due to family issues, caste issues, everything. And finally, the heroine will say to the hero, okay, everything is, now we are separate. So you find out your love tomorrow, you start your new life, you start a new beginning. Then the hero will say, what are you talking? How can I do, like tomorrow I will find out my love, I will start a new life. It is something like love will come to your doorsteps and knock, and then you will feel that love. That is what is meant by love. Like that, passion also comes and knocks at your door, and you find that this is your passion. Something, when you do, you get a lot of happiness and you feel that you are complete. So passion again provides self-relief, creates better self-esteem, and creates resiliency. And these are the advantages with dancing and mental health. With any other passion also, you'll have the same feeling, like it eases depression, lessens loneliness. Now, when you do a work or creativity with persons who also have the same feeling, I think your results will be much more than what you expect, or it will give you surprises. So this was a dance album which I did with the playback singer Mrs. Akila. You know her. She was also a very good person to work with. So when you do your work with a person who thinks like you or who behaves like you, your work will get more appreciated. That is the same thing with Zumba dancing or yoga and all. When you do with a group of people who have the same wavelength, the productivity will be more, or you will be feeling much more happy than you do it alone. And thankfully this video was viral during that time. This is again with Dr. Anita Unni. I shared a stage in KSOS. So when passion blends with profession, it becomes a masterpiece. For certain people, as Latika madam told, their profession itself is passion. That is a dangerous combination. For doctors, it will be very good. But the problem is that there will be always some compromise when you concentrate on two things. When I dance, I know I can never dance like Star Wars in that field, like Padma Subramanian or anyone. It is just for my happiness that I am dancing. It is not for the acceptance of someone else that you should do your passion. So after I shared my thoughts in a similar talk, one of my students who was very shy to sing, she was a good singer, but she was very shy to present it before someone. She started singing and she started posting it in her WhatsApp video, FB and all. And I also felt happy that those who are hearing the talk also takes it into your life. So this was a movie which I acted last year with Washi, and I was lucky to share the screen with these two very lovely persons I met in my life.
Thank you, Dr. Arya. It was a wonderful presentation, and we had a glimpse into how you have pursued your passion. So now I also understand that there is a social pressure to pursue your passion. While just like she said, passion comes and knocks at your door. But it is okay not to have a passion at all also. So that is something I think,
correct.
Because a lot of people, now feel that, okay, I am only doing so much. Because others, like she said, don't look at the others. So this is about choices. So again, I come back to that, a very important thing, that feel free to have choices. It is okay not to have, what you do, if that is little or that is, you want to sleep in your spare time, that is perfectly fine.
Yes, yeah, correct. While I was preparing this PPT, I had told it in my previous talk also. My son was relaxing and seeing the TV. He was watching it for 2-3 hours, relaxing like that. Then I came and told, what are you doing? You study, you are in 11th standard, you study. Then he was telling, what are you doing? Then I told, I am preparing a PPT for my presentation and the topic is passion and profession. Then I again compelled him, get up from the sofa, you go and study. Then he told, Amma, do you understand one thing? Lying like this, relaxing, seeing the TV, watching the cricket show, that is my passion. You also understand that. So passion differs from person to person.
So just adding on to that, I feel it very strange that this question comes up, like how do you manage to balance passion and profession? I mean, passion is just what you feel. It is just a state of mind. Whether I am in my profession or whether I am writing or whether I am dancing, I can do it passionately. So it is not something we are balancing. It is something that is coming to us, whatever we are doing. I mean, it is not necessary that someone should dance or write to have a passion. So it is just a state of the mind. That is what I want to say. And let me leave you with this beautiful thought, which is not mine. I am just quoting from The Prophet by Khalil Gibran. And this has stayed with me, and I hope it will with you also. He says, let your head rest in reason, and let your heart move in passion. So if you have this glorious combination, there is nothing you cannot do, actually. The more you think about it, the more you will understand it.
Yeah, that's a very good thought, really, Dr. Latika. Khalil Gibran's all verses make us think a lot and get a lot of points. The talk was really interesting, really beautiful, just like you, Arya. And I should be saying that I'm truly honored. I was truly honored to share a stage with Arya for KSOS as well. And one thing, what Dr. Merin said, each person has their own passion and there's absolutely no reason to be shy about it. As they say, passion is something you do, passion is something what you love, and profession is something what you do to get a living. So, but to be successful, when you start loving the work you do, whatever be it, there you have the success. So, thank you very much, Dr. Arya. And shall we move on to our next talk by Dr. Ambika? Dr. Ambika is a great friend of mine. She is a managing director of Geetanjali Eye and ENT Hospital, Trivandrum. She did her master's from Minto in Bangalore Medical College, and she has done fellowship and she has done lots of activities, lots of talks, and she is also an LDP alumni from AIOS. She's a very good phaco surgeon, but at the same time, and she has held several positions in various organizations, including Kollam Ophthalmic Club, the Innerwheel Club, etc. But one thing what makes her stand apart, I think, is her passions of which focus more on fitness. I'm not saying more on fitness, also on fitness, because that gives her happiness to her heart as much as dancing gives Arya and all other passion gives, all other activities are done. So she has combined it with her fitness activities as well, because she is a very good yoga practitioner. She has joined for Kalaripayattu recently. And one more thing is, many of us would have done yoga. Many of us would have done various courses, but I've seen hardly very, very few people who really stick on to it, meticulously practicing it every day and getting a spiritual evolution out of it. Hearty welcome, Dr. Ambika. The stage is yours.
Thank you, Dr. Anita, for that nice introduction. And first of all, at the outset, I would like to thank the Kollam Ophthalmic Association, both the veterans and the youngsters. It's really nice to be here in this very vibrant group. Coming to my topic, which is investing in yourself, that is fitness for a busy ophthalmologist. As an ophthalmologist, one has to balance family, life, our work. Then there is a lot of responsibility. Some of us might have even be involved in administration. So amidst all this, what about our own health? So that is what we are here to talk. So in our practice and even in our family life, we come across several mental health challenges. So what are the specific things that ophthalmologists might come across? There is a steep learning curve in our field. There is a high investment both for time and in terms of finance. And also there is a risk of litigation. So because of this, definitely we are more prone to stress, anxiety, depression, several mental health issues. Coming to the physical health challenges, we work in odd postures. Pediatric ophthalmologists have to do retinoscopy in awkward positions. Then we are also doing sedentary work. Surgeons who have long lists, they have repetitive strain, they're prone to neck and back issues. And also our work spaces are quite cramped. So coming to the question, why fitness? So when as a clinician, you're advising your patient, you need to lose weight, you need to control your diabetes. Obviously, you have to walk the talk. The patient is going to believe you only if you are doing something. So sometimes even patients might ask you, doctor, are you really doing something? Several of my patients have asked me, what is it that you practice and how do we go about it. So actually many of them have got inspired and have taken up fitness. So looking at the lives of some of our colleagues, most of us will know Dr. Anaga. So Anaga and I were there in a meeting together, and she was telling that she recommends anaerobic exercises that require short bursts of energy. We know that after the age of 27, we start losing our muscle bulk every year. So as we grow older, it's very important for us to exercise and maintain the tone of our muscles. So this we can get only by doing anaerobic exercises. And another doctor, who is Dr. Chaitra, she says that she is actually a practitioner of kickboxing. So she says this is a way for her to look younger, and also she likes the compliments that and appreciation that she receives from others. So coming to how much do we need to exercise? So at least 150 minutes of aerobic exercise and 75 minutes of anaerobic exercises are required at least once a week. And it's important to include strength training at least twice a week. So what is anaerobic exercise? It means we are creating a situation where the demand for oxygen is more than supply. So this increases the lactic acid in the body. So this improves the performance of our muscles, and also it improves our endurance. So when we are planning a fitness schedule, it's important to include endurance, flexibility, which makes our day-to-day tasks easier, balance so that we can prevent falls, and also strength building exercises. So how to go about it? So first thing is, according to your interest, just choose some activity. Then at least like say 1 month goal, 6 month goal, you make short-term goals. And then decide, okay, you might have a busy schedule, but at least start once a week, twice a week. Then you see the endorphins, how it starts making a difference to you. And then give some time for that. And also, when you're making the plan itself, you should see, okay, let me choose a place where there's no distraction. First of all, try to keep your mobile phone away, and then try to focus on your fitness activity. So when we start any activity, obviously there'll be barriers. So we can come up with multiple excuses, say not convenient, I don't enjoy it, there's a fear of injury, I don't have access, I don't have time, lack of energy. But with patience and persistence, definitely you can overcome these obstacles. So this is my fitness schedule. Thrice a week, I have a group with whom I practice Kalaripayattu. And the other 4 days, I practice yoga on my own. Yoga I've been doing from last 7 years. So in terms of my mental health, it has given me a lot of balance and stability, and also flexibility. But what I learned, this Kalaripayattu I've been practicing only from last 6 months. So what I've noticed with that is it gives me the opportunity to stretch myself a little more. As in, there are repetitive exercises, that the anaerobic exercises that I was talking about, that is there in our own Indian fitness forms. So with which we are able to stretch ourselves further and perform better, both in terms of our body and in terms of our profession. So I would like to share this experience, which was just 2 weeks ago. It was a very difficult case. The patient was quite overweight, as you can see, and the patient had a short neck. So there was no way this patient was going to lie down for the surgery. In spite of a lot of mock practice sessions in the theatre, patient said, I'm not going to lie down on this operation theatre table. So this surgery had to be performed standing, and it was almost like there was a lot of positive pressure, upthrust, and 1 foot on the phaco pedal. I had to balance 1 foot on the ground. So I feel my fitness routine and yoga really helped me in this particular situation. So I would conclude by saying that your body can almost withstand anything. It is only the mind that you need to convince. And definitely you have so many apps and watches and all kinds of gadgets these days to help you monitor and motivate your fitness goals. So thank you all for your patient hearing.
Thank you, Dr. Ambika, for that really inspirational talk. Because one thing I think which is different from following your passion is when it is not your passion and you still have to follow it, like, you know, because I think following fitness goals may not be your passion, but you still have to do it, because as you all know, we as a profession, as doctors, as healthcare professionals, are much more prone to lifestyle diseases, and, you know, because we always think that all those diseases happen to, you know, the patients. We are something special, we are not. And given that our mortality rates are higher, definitely I think every word that she spoke has to be taken to heart, because like we tell our glaucoma patients, if you start young, you will, you know, extend your, in this case, your life much more if you follow these. It's hard, I agree it is hard, but definitely I think all of us need to take a leaf out of Dr. Ambika's book and follow fitness goals. Thank you so much, Dr. Ambika.
Thank you.
Anita, can you wind up?
Yeah. So yeah, that was truly an inspirational, motivational talk. To smile when your muscles are aching is it's not an easy thing, I think. And also to find happiness in improving our fitness is also very, very important. As Dr. Merin mentioned, we need to all address it, and I hope all of us get the inspiration and motivation from Ambika's talk and start some kind of activity, as she mentioned, and to take care of our health. ചുവരുണ്ടെങ്കിലേ ചിത്രം വരയ്ക്കാവൂ. I need not say that again to all of us. And not only that, as she mentioned, the fitness activity also helps us in improving the health of our mental health. Also our attitude and our mood also changes, which helps us to become better practitioners as well. So thank you very much, Dr. Merin and Dr. Latika, and all the speakers in this forum who performed, who gave a very good talk and very interesting sessions to all of us. And thank you very much, Kollam Ophthalmic Club, for giving us this opportunity.
Thank you so much for that impactful session.
Once again, thank you, Chaos, and all the so it was a wonderful conference, I think. Really a conference with a difference.
YOLK young ophthalmologist, really very promising.
We are extremely happy to have Dr. Arup Chakrabarti sir with us today. Hearty welcome, sir.
Next, we have the memento distribution. May I request Dr. Mini Jayachandran, KOA President, to hand over our token of appreciation to the panelists and speakers. Dr. Marine Paul, ma'am, please come forward. Thank you, ma'am. Dr. Latika Vasudevan. Thank you, ma'am. Dr. Anita Prabhakaran. Thank you, ma'am. Dr. Shweta K. Thank you, ma'am. Dr. Ambika Shetty. Thank you, ma'am. Dr. Prithvi Chandrakant. Thank you, sir. And Dr. Shruti.
Can we have a group photo of the whole session?
Sorry, ma'am, sorry. Dr. Arya R. I'm really sorry, ma'am.
all the speakers, can you just come forward? We'll have a group photo.
A message to the for reminding the PGs here. Next weekend, Saturday, Sunday, we have a PG teaching program at Chaitanya. You will be aware of that. And many of the PGs who are here are already registered. We have, it's limited to 50 PGs. So we have few more slots available. So PGs here who have been registered, it's just a reminder for them. So today also we have put that in the KSOS group. So you can, there's a link there, you can register through that. If you see that message which we have posted today, you can register through that, and this is a reminder for you. Thank you.
Please fasten your seat belts, for you are in for a ride. Get ready to see our residents in an action, in a battle of wits and intelligence. We present you the most exciting part of YOLK Inside CME, the quiz competition for the residents. Let me hand over the session to Dr. Anjana, the quiz master.
So good afternoon, everybody. I welcome you all to this small quiz session. So I invite all the 4 finalist team to come forward. The names were called earlier. I request all the 4 team members to come forward. All the team members to come forward, and 1 member from each team to take up the lot. So who is team A? Team A? Team A, yes. Kindly take your seats. Team B? Team C? And Team D. Kindly take your seats.
Hello, am I audible? Yes. Yes. So, warm good afternoon to one and all. So, we had a very elaborate preliminary session for the quiz, which was conducted early in the morning. Had a total of 22 teams which participated for the quiz prelims, and we had very hard time to select the best 4 team as the finalist. So first of all, let me congratulate you all for being in the finals. And I welcome one and all, every single member. I think there is.
Yes. Okay. So we don't want to create any confusions in between the quiz. So I'll be taking this mic forward. Okay. So let's have the teams getting introduced yourself. Team A, can you introduce yourself?
Myself, Dr. Dimple from Dr. SMCC Medical College, Karakoram, Trivandrum.
Yes. I am Dr. Arya from Karakoram Medical College.
Okay. Team B?
Dr. Sahala from RAU Trivandrum.
Okay.
Dr. Devika from RAU Trivandrum.
Okay, thank you. Team C?
Dr. Sri Lakshmi from Kollam Medical
Okay.
College. Dr. Sibilia from Kollam Medical College.
Okay, thank you so much. Team D?
Dr. Devi from Kottayam Medical College.
Yes.
Dr. Ashwati from Kottayam Medical College.
Okay, thank you so much. So for this quiz, we have actually formulated 4 rounds. So I'll be giving the exact details of each rounds just prior to the corresponding rounds to create no confusion. Okay, so myself, I'm Dr. Anjana. I'll be the quiz master for the day, and the quiz master's decision is considered final, as you can expect in any other quizzes. And I cannot start the quiz without mentioning my team members' name, Dr. Lakshmi Sri and Dr. Jubeira, who were actually the brains and brains behind the quiz. Okay, so I'm not the only person who created this quiz. So let's not waste any time. So let's have the round. So we stand on the shoulders of our ancestors. The first round is history round. So the general rules for this round is, a photograph will be shown to you with certain clues. You can identify the personality from the first slide itself. You'll get a total point of 20. There is a time for 30 seconds. If you find any difficulty, you can ask for an additional clue. But if you're answering on the additional clue, your marks will be cut short to 10. The questions answered wrong, or if your time is up, the chance will be passed on to the next team. But if the next team, if it is a pass question, they'll be getting only the half the marks. So if the pass team is answering on the first clue itself, they'll get 10 instead of 20. And if it's answered on the second clue, they'll get 5 instead of 10. Is that clear? Yes. So we'll be going in the regular order from A to D. So first chance for team A. Are you ready? Yes. So this is a German ophthalmologist. He is considered the founder of modern ophthalmology. He used iridectomy as a measure to lower intraocular pressure. Your time starts now. You can ask for clues if you need. You have an answer, yes. Clue. He introduced this instrument which was widely used in earlier days of cataract surgery. Yes, correct answer. 10 points since he answered on the second clue. Yes, the answer is Albert von Graff. He introduced the von Graffi knife and also this von Graff sign in exophthalmic goiter and all these things. Very, very familiar name. So direct question to team B. He's a famous Indian ophthalmologist, recipient of Padma Shri Award. He had to leave the Indian Army due to rheumatoid arthritis, And you can imagine how difficult it would have been with the starting his career in ophthalmology with the crippled fingers. Yes.
Venkatasamy.
Yes, correct answer. 20 points for team B. Well played. He has also done major role in Indians NPCB programs. So who is he?
Founder.
Yes, exactly. He's a founder and the former chairman of Aravind Eye Care Systems. So direct question for team C. Ready? Yes. So very famous Swiss Austrian ophthalmologist who was an assistant to Anton Elschnig. He modified slit lamp and many ophthalmic instruments which is widely used by every single ophthalmologist worldwide. So audience, please keep your thinking process in the low voice. If you want, you can ask for an additional clue.
Yes, ma'am.
Clue. His name is associated with enhanced S-con syndrome. Yes. Your congeners are very eagerly waiting to answer. His time is up. Team D. Team D, you have an answer?
Pass, ma'am.
Pass. Team A?
Goldman.
Correct answer. So 5 points for team A. So what is this? What is the other name for?
Goldman Favre.
Yes, Goldman Favre syndrome. Very good. Well done. So the direct question and the last question in this round for team D. Team D. This is Scottish surgeon and ophthalmologist. He described the properties of isostigmine, which actually became the very first meiotic to use in ophthalmology practices. And he also published some profound surgeries which became the key for most of these anti-glaucoma surgeries. Very famous, very famous. You want an additional clue? Yes. This is your clue. Is everybody is thinking here? Marcus Gunn, wrong answer. Team A.
Answer in your mind.
Answer?
Banherick.
What?
Banherick.
Wrong answer. Option?
Kestemban.
No, wrong answer. Team C. Pass. Audience, anyone? Yes, very good. This is me. Douglas Murray Cooper, lamp, Argel Robbins. That the picture was the second clue was actually the Argel Robbins pupil. Okay, so that comes the end of round 1. So we'll have, this was an additional question. How can I forget my audience, my dear audience? So by the time I'm having some interactions with you, let my team members calculate the scores for the round 1. One among these Bollywood stars had actually underwent LASIK surgery for correcting presbyopia. Yes. Shah Rukh Khan. Yes, the one bold girl who has answered, raising her hands, deserves a clap as well as a gift. So your name? Rashmita. You're from? Okay, wonderful. Congratulations, Rashmita. The answer is correct, Shah Rukh Khan. Okay, so is the scores ready? Yes, we can.
So at the end of first round, we have Team A with 15 points, Team B scoring 20 points, Team C and D yet to score.
Yes, okay. Don't worry, C and D, you have upcoming rounds to score. Okay, so let's move on to the round 2, which is again, I'll be going from A to D. Okay, so in this round, there is no pass. Questions to you will not be passed to the next team. So your job is, actually we'll be showing 3 figures. And connecting these 3 figures, you can arrive either at a clinical systemic condition or you can arrive at an ocular condition. Common, connecting all these 3 pictures. Okay, so your job is to find out the condition. Simple. There is no negative mark. Only one answer is permitted in one attempt. And the time for your answering is 20 seconds. Okay, team A ready? Yes. The time starts now. the three images which are projected. Connecting these three images. Yes, you have an answer?
Beggar syndrome.
Yes, correct. Vaginous granulomatosis. Correct answer. So why did you say it is Vaginous granulomatosis?
Wilms tumor.
It's not Wilms tumor. So basically it is a segmental glomerulonephritis that you get in vaginous granulomatosis. This is necrotizing scleritis and the saddle nose. Okay. So what's the other name for vaginous granulomatosis? Newer name? Granulomatosis with polyangiitis. Correct answer. So team A has scored 20 points. So team B, ready? Your time starts now. Very simple question. Toxocariasis, correct answer. So why do you say it is toxocariasis?
Granuloma connecting to the
exactly, there is a typical peripheral retinal granuloma connecting to this optic disc. And the initial two pictures, the first picture is actually the visceral larva migrans. The arrow is showing the hypoechoic region which is seen in the liver. And the second figure is actually the parasite itself. Okay, so 20 points for team B. So team C, are you ready? So your time starts now. You can arrive at the ocular diagnosis. There is no pass. Even then your friends are thinking. Audience are also thinking, so which make me happy. Right? Your time is up. So anyone from the audience? Lipemia retinalis. Edwin sir has raised his hands. Okay, so this is lipemia retinalis. It is a condition when the hypertriglyceridemia occurs, and you can see that milky white colored retinal vessels when the triglyceride level is more than 1500, and also you get a typical salmon colored fundus, background fundus changes when the levels are more than 2500. Okay. So team D, direct question to you. Time starts now. There are three images, just need to connect them. You might get some additional clue from the third image. No whisperings, please. I can. Yes.
Stickler syndrome.
Yes, correct answer. 20 points for team D. It is Stickler syndrome. What is the fundus finding that you can expect in case of Stickler syndrome? Can you explain the third image? Of course, I'm not going to cut your mark. You can say loudly. The vitreous bales, the beaded vitreous that you get typically in case of this Stickler syndrome, and the first image is showing the mid-facial maldevelopment in children, especially those with the Speary-Robin sequence, and the second one is also very typical V-shaped cleft palate that you see in case of Stickler syndrome. There are lots of types of Stickler syndrome, and ocular features are not present in every case. Okay, so that coming to the end of the round 2, I'm not wasting my time. I'm straight away moving to round 3. Okay, so I'll consider you audience after my round 3. Okay, so this, since the initial round was from A to D, let me start from U. Okay. That's the next question. Round 3. Okay, so this round is very simple. Spot the sign. Okay, so you will be shown a picture, just a picture. So from that picture, you can identify an ophthalmic sign, very, very familiar ophthalmic sign. You have to say what is that sign, and you have to identify in which condition you see that sign. Okay, so there are basically 2 parts for every answer. So a complete answer will be getting a point of 20. There is no negative mark. Unanswered questions will be passed on to the next team. So definitely if you're not answering, team C will get a chance. Okay. So if you're getting partial answers correct, that means you are getting the sign correct, you don't know the condition, then you will get only the half the marks. So you will get only 10 points. But in that case, the question will not be passed since it's a partially answered question. And if it is a past team answering, again, you will get 10 points if you correctly say both the parts of the answers, and you will get only 5 points if you say only one part. Clear? Clear. Okay, so so in nutshell, you have to say the sign and also you have to identify the condition. So I'll show a clinical example. So from this image, audience, yes, frosted branch angiitis. So it is basically frosted branch angiitis and usually seen in CMV retinitis. Like that, you have to say both the part of the answers. Okay, shall we move? Okay, so direct question to team D. $20 seconds for answering. Yes?
Bare protract appearance.
Yes, correct.
Congenital hypertrophy.
Yes, correct. So it's a bare track sign seen in congenital hypertrophy of retinal pigment epithelium. Well played. Yes, this is a picture of the bare track lesion seen in the condition. And team C, ready? Yes. Sharp fin, no. Team B, you have given a wrong answer. I'm passing to team B.
So neck deformity.
No. Wrong answer. Team A. Yes. Do you have any answers? Can you see the image clearly? It doesn't appear swan, right? Yes, your time is up. Team D. Answers. Yes, I think. Yes, correct. Correct.
Loch Ness monster.
Correct. Loch Ness monster appearance. Do you know where it is seen? Condition in which it is seen? So I can give only 5 points to team D. Okay, so this is exactly what she told. This is Loch Ness monster appearance. This is a peculiar vascular loops in the angle when you do gonioscopy in case of congenital glaucoma. Okay, so that creates 5 points for team D. And next, direct question to team B. Ready? So 20 seconds starts now.
Splash milk appearance in glaucoma flecken.
Yes, correct. 20 points. Splash milk appearance in glaucoma fleckens. Correct answer. 20 points for team B. Yes, this is the typical spill milk appearance or splash milk appearance you see in glaucoma flecken. Team A. Ready? Yes.
Candy vaccine.
It's candy vaccine. The wrong answer, team D.
Candy.
Your time is up. You already told candle wax and candy straw. Team D. Your team is. Team C. Candy stripe sign. You say the condition and then you will get 10 points.
Uveitic glaucoma.
It's not in uveitic glaucoma. I'm giving you 5 points. Okay. So this is seen in ghost cell glaucoma. Ghost cell glaucoma. The typical khaki colored cells seen in ghost cell glaucoma. Okay. So with that, we are coming to the end of round 3. Okay. So Dr. Jubaira and Dr. Lakshmi, please calculate the scores till now. And anybody from the audience? Yes. Flying saucer sign. Which condition? Yes, exactly. I think she deserves a clap for that, for a right spot answers. Again, don't worry, audience. I have more questions to you. So connect all these pictures and you will arrive at a common term. Anyone? Kindly raise your hands and answer so that I can see clearly. Biju sir has raised his hands. Kindly. Biju sir is getting a prior chance because... No sir. Anyone else? Chaitanya ma'am. Anyone else? The chocolate is waiting. It's not gout disease, sir. Yes, exactly. Leber. So this is Leber's miliary aneurysm, LHON and the Theodore Leber himself. Yes. Again, Doctor, I forgot your name. Yes, Dr. Reshmita from RIO, right? RIO has again scored questions for audience. One more question, I think, for audience. It's out of ophthalmology, but still you can identify the face from the very peculiar eye. You can also think. Yes, Rajiv sir had answered. Afghan girl. Yes. Sir, can I know the name of the girl? Yes, I think Rajiv said this is a chocolate because that was a very quick answer. So this is Sharbar Gula. What is the peculiarity or what is the specialty with this girl? Yes, exactly, madam. So the photograph of this girl was taken during the Afghanistan war back in 1980s, and the identity of the girl was not relieved. Even though the photographer tried so many times, he couldn't find out the identity of this girl. But later, after 15 to 18 years, the identity was again found out. And so this is the only picture National Geographic magazine has picked as a cover image thrice. The only picture which has repeated as a cover page of National Geographic magazine. So very typical the staring look of this girl has been haunting all the minds and reminding of this Afghan war everywhere. So that was also very nice. So can I have the scores? Yes.
At the end of third round, we have Team C with 5 points, Team A scoring 35 points, Team D scoring 45 points, and Team B leading with 60 scores.
Okay, now that Team B is leading with 60 points. So we are coming to our last round, but believe me, this is a tricky one. You can score more marks and you can beat everybody else in the other teams. So this is a rapid fire question. So you have to be very vigilant. So I'll be giving you a total time of, team members kindly listen, you'll get a total time of 45 seconds. And a set of 7 questions is awaiting you. Okay, so I'll be reading each and every question. If you're stuck with any answers, you have to say next question or pass. Otherwise, I'll be there. I'll not read out the other questions. So if you don't know the answer of any question, you just say pass so that you can have more questions and more marks. So every single correct response, you will get 10 points. 10 points. And every wrong answer, minus 5 points. Clear? So there are 7 questions. There is a total time of 45 seconds. 10 points for correct answer and minus 5 points for every wrong answer. So again, I'm starting from Team D. So Team D, your first question, time starts now. Direct ophthalmoscope gives a real inverted image, true or false?
True.
Wrong answer. A wave of ERG originates from which retinal structure? If you don't know the answer,
Pass.
you pass. Lander's sign is?
Pass.
Most common systemic disease associated with childhood anterior uveitis. Correct answer. 10 points. Volume of orbit is dash ml.
30 ml.
Correct answer. Identify the site of lesion.
Vandenberg's limb, optic chiasma junction.
No, your time is up. Your time is up. Okay. So the direct ophthalmoscope gives a real inverted image. That is a false statement because you get a virtual and erect image. A wave of ERG originates from photoreceptors. Lander's sign is a specific that granuloma, retinal granuloma seen in case of sarcoidosis. Most common systemic disease, you have done it right. That is juvenile idiopathic arthritis or JIA or JRA. Volume of orbit is 30 ml. And I want the specific site. So that is basically anterior will brand of knee and that to right side. So you have to be very specific for that time. Okay. So the next question you didn't get an opportunity to answer. That is a TNO test. TNO test. Okay. So the chance of team C. You ready? So you have to be very quick, vigilant. Peace of mind is a key. Okay. Time starts now. Bone marrow suppression is a common adverse effect of mycophenolate mofetil. True or false?
False.
Correct answer. Tooth giant cells are diagnostic of?
Pass.
Boston sinus?
Pass.
Most common type of rhabdomyosarcoma?
Pass.
Applanation tonometry flattens dash millimeter squares?
3.08. 3.0.
Wrong answer. Identify the condition from the diplopia chart.
Inferior oblique.
Not only inferior oblique.
Right inferior.
No.
Pass.
Identify the sign. Your time is up. Answers? No. So let me tell you, bone marrow suppression is a common adverse effect of mycophenolate mofetil. It's a false statement. But it's very, very rarely seen in case of mycophenolate mofetil. And two-tone giant cells are diagnostic of xanthogranuloma. Xanthogranuloma. Boston sinus seen in thyroiditis. That is a very peculiar jerky movement of the upper eyelid when the patient is looking down. So that is called Boston sign. Most common type of rhabdomyosarcoma is embryonal type. Embryonal type. Applanation, you were very close with that answer, but that's a very basic question. That's why I'm not giving you marks. Okay, you answered 3.08. That is 3.06. 6. So this is third nerve palsy. Okay, right, third nerve palsy. And this is bullseye maculopathy. Bullseye maculopathy. Okay. So I think the scorers are also vigilant, right? So can I move to team B? Ready? Yes. Team B is so under pressure that that's a leading team, and there is a chance that the lead may all the best. Okay. I can only say that. So that's the answer for the team B. Your time starts now. FM100 uses 80 plates. True or false?
False.
Correct answer. Tiprotumumab is a drug for the treatment of dash.
Thyroiditis.
Correct. Kestenbaum sign is? Pass. Most common peripheral neural tumor of orbit? Pass. Posterior chamber contain dash ml of aqueous.
0.06.
Correct answer. And name the material by which this implant is made.
Nickel and titanium.
Yes, correct answer. Nitinol. So spot the sign. So your time is up. Time is up, right? So you're not getting the chance to answer the final question. So FM100 uses 80 plates. True or false? It's a false statement. It uses 85 plates. Okay, 85 plates. That was quite tricky one. The second question was answered right. It is used in thyroid eye disease, Kestenbaum sinus. I think you know the answer. So it is a decreased number of capillaries seen on the optic nerve surface, seen in optic atrophy. So most common peripheral neural tumor of orbit is plexiform neurofibroma. Posterior chamber, you answered right, 0.06. Nitinol answered right. And can you answer the last question now? You'll not get any marks, of course. So that's a tall peaked PED. Tall peaked PED. Okay. Okay. So final question for team A. Ready? Your mic is all right, right? So kindly answer in the mic so that I can hear the answer. Is this not working? Please check it once. Yes. Okay. So your time starts now. The tight corneal sutures can lead to against the rule astigmatism. True or false?
Pass.
Groove and peel technique is
Pass.
used in Ferry's line is
Deposition of iron.
Iron.
Pass.
Most common secondary tumor in patients with retinoblastoma. Secondary tumor.
Pass.
Pass. The intraocular part of optic nerve measures dash millimeter. Very simple question. Anatomy.
25.
No. Wrong answer. -5. Identify the site of lesion. You can do
Occipital lobe macular sparing.
it. No, wrong answer. Again, -5. Identify.
Choroidal neovascularization.
Yes, exactly. Choroidal neovascularization. That's the right answer. So tight corneal sutures lead to against the rule astigmatism. It's a false statement. It lead on to with the rule astigmatism. Groove and peel technique is used in manual DALK. Okay, manual DALK. Furry's line is, you answered it partially. It's iron epithelial line seen in anterior part of trabecular bleb. Most common secondary tumor in patients with retinoblastoma is osteosarcoma. This is very simple. Pie on the floor appearance. Yes, parietal lobe, and the last one was answered correct. CNVM. So what was that imaging modality? You know that? Yes, exactly. Excellent. So there comes the end of your rounds. You can breathe peacefully. And let's have some fun for the audience. I had some extra questions. This is not for the audience. Kindly don't answer. Please calculate the marks. Was it simple than the questions you got? Okay. So audience question. Kindly raise your hands and answer. Whose drawing is this? Whose drawing is this? Mahadevan sir. I can't give chocolate for that. I can have answers from Mahadevan sir, but of course the answer is not Mahadevan sir. Anybody? Yes, madam? No, ma'am. That's not payment. No, sir. Again? Correct answer. Again from Team Mario. This is Da Vinci. Okay. So this is Leonardo da Vinci. And the next question for audience. That part of the image which others call red appears to me little more than a shade or defect of light. After that, orange, yellow and green seem one color, which descends pretty uniformly from an intense to a rare yellow, making what I should call different shades of yellow. Just in love with the YOLK team, all shades of yellow. Whose words are these? No? Yes, somebody spoke. Yes, sir? Yes, exactly, Dalton. John Dalton. He deserves a chocolate. So he was colorblind by himself, and his brother was also colorblind. So he had formulated lots of theories in color blindness, apart from these atomic theories that we hear from in that name, John Dalton. So with that, our audience round is also over. Are the scores ready, Dr. Jubeira? So let me say in this, I have already told that there were 22 teams and we could only select 4 teams. And the first prize is a cash prize of rupees 10,000. The second prize is again a cash prize of rupees 5,000. You will have to share among yourself. And the third prize is also cash prize, rupees 3,000. Actually, 2 teams from RIO Trivandrum had qualified, had become, more marks. But since the rules were like, we can only allow 1 team per college for the final team, since these teams scored a little bit more than you, that's why you are, but I'm sure that you can score much more in the upcoming quizzes. You're all well versed with quiz. So in meantime, I would like to invite Dr. JP sir. He is here. Yes, sir. Kindly announce winners. The scorecard is ready. So I would like to thank Dr. Rajiv sir with his ideas and helping us, guiding us with all these things, even the minutest of things. Yes, the sir is coming with the...
Yeah, thank you. Madam, that was a wonderfully conducted
Thank you so much, sir.
quiz. Excellent, actually. First time she is coming on stage to conduct a quiz program, and she did it extremely well. These people have spent a lot of time. She, along with her team, has done a lot of work behind this, a lot of work. I think she needs to have a good applause. And I'm glad that you people have come today and joined us. I'm extremely happy. I may have personal bias towards RIO because my better half is in RIO. But I am also with Kollam Medical College because I was a faculty there for a long time. So then there was a lot of, I was unsure as to whom I should support and clap for. And let me announce the results. And the third prize goes to Team A from Karakonam with 35 points. Please come to the stage. Third first. Come.
Congratulations, Team A. Well played. I know you know much more than these answers, but in the time period, it's difficult to recall.
Prize is ₹3,000.
Yes.
You have promised to share it with me.
Yes. Congratulations.
Team which came second is Kollam Medical College.
Yes.
Team D.
Congratulations, Team D. So, Team B, second prize, getting 5,000 rupees. You can share it with your team member. And Dr. JP, sir. And me, of course. Certificates. This is the most important part, right? Congratulations.
And the first prize is Team B, all the way from Trivandrum, RIO.
Yes, let's
Please
have
come
a
out.
good round of applause for Team B. And these people, no wonder, they have also scored the highest marks in the preliminary session as well. Very well played. Congratulations. Yes, first prize is rupees 10,000. So congratulations. And they have decided not to share with JP sir, but with Dr. Smita, which is again going to the same home. Of course, the hot seat itself is a consolation prize, sir, because there were lots of team members, 22 team, and making it up to the final four is again a very huge success. Okay, congratulations, Team C. Okay, so thank you all. Thank you, JP sir. Thank you, audience. Thank you, my team members, my friends, Dr. Lakshmi Sri, Dr. Jubeira. Thank you all.
We will be having a Kollam Ophthalmic in October. The date will be announced. We will be having teachers of tomorrow instead of quiz during that Kollam. That's for the postgraduates.
Congratulations to the winners and all the participants. Now we'll move to the last session, clinical potpourri. We should not stumble on certain clinical situations which we commonly encounter in OPDs. Our next session will be guiding us how to deal with some common conditions.
Welcome the panel. I invite Dr. K. Mahadevan sir to chair the session. He is retired professor from RIO Trivandrum, has special interest in vitreoretinal surgery. Currently, he is the head of the department at Sri Kollam Medical College. Welcome, sir.
Dr. Biju Johnsy, Professor and Head of the Department, Government Medical College, Kollam. Areas of expertise are vitreoretinal surgery, medical retina, phacoemulsification, and SICS. He has received many awards for the best video presentations. Welcome, sir.
Let me welcome the moderator for the session, Dr. Edwin James. He is Assistant Professor at Government Medical College, Kollam. His areas of interest being refractive cataract surgery, retina, and pediatric ophthalmology. Welcome, sir. Now, may I hand over the session to Dr. K. Mahadevan, sir.
Yes, thank you very much. We are running out of time and I'm very hungry also, so we'll try to finish fast. I welcome all my colleagues here sitting on either side. I'll invite Dr. Who is the first speaker? Shishir, yeah. Anybody who can introduce?
Dr. Shishir is the Managing Director and Consultant Vitreoretina Surgeon at Amrita Eyes Care, Tiruvalla. He's done his MBBS and MS from Christian Medical College, Vello, Fellowship Vitreoretina Surgery, and ex-consultant at Arvind Eye Hospital, Coimbatore. He has also finished his FICO and FAICO Retina. He has 38 PubMed indexed publications, instruction courses and presentations in AIOS, KSOS, TON, and UC. Welcome, sir.
Thank you, sir, for those introductory words. And thank you, Kollam Ophthalmic Society and YOLK for having me for this session. I don't know how I can cover DME in 5 minutes, but I hope I'll make it interesting. So no financial interests. So what is DME? It's retinal edema threatening or involving the fovea due to diabetes and leading to vision loss. So for the PGs, it's basically leakage from the microaneurysms or from the leaky capillaries due to the loss of pericytes, and the fluid tends to accumulate under the retina, especially at the macula, and leads to edema. So first thing is update on the definition of DME. So nowadays almost all the institutes have OCT in their practice, and nowadays we have OCT to diagnose as well as define diabetic macular edema, and based on the OCT we have center involving and non-center involving DME. So our PGs who are having exams, they'll still be asked what is CSME, and then you'll need to give these definitions. But now in the current practice, management practice, we usually go ahead with the treatment based on not FFA, not the clinical exam, but based on the OCT. So on OCT, DME can be center involving, especially when the center subfield is not involved. It's called non-center involving, and here you can see in the 6 mm scan that the center is not involved. It's a normal foveal center, but the subfield thickness is increased, and that's a non-center involving DME. Then we have the center involving, where there is edema of the center of the fovea, and you can see in the 6 mm subfield that there is increase in thickness of the foveal center. So this is a center involving diabetic macular edema. So you need to differentiate this from mechanical causes of edema, especially when you have ERMs, taut hyaloids. In patients with PDR, you need to differentiate them, that you need to have surgery to resolve the edema rather than keep injecting with anti-VEGF agents. So I'll quickly jump on to management. We do have a lot of options, anti-VEGF injections, steroids, and we also have laser. And all this has been studied in multiple studies. I won't go too much on the details. Now for the PGs, how each one acts. Laser acts on the RPE and helps in stimulating the RPE to pump out the fluid. Intravitreal anti-VEGFs act on reduce the VEGF levels and reduce the edema. Steroids act on the inflammatory mediators and reduce the edema. And vitrectomy helps in improving the oxygenation as well as removing the inflammatory mediators from the vitreous, and thereby helps in decreasing the edema. So always a systemic control is extremely important, and it remains the hallmark for prevention and progression of DME. Along with that, you need to tell the patient to get their CKD also under control, anemia correction, avoid rosiglitazone, pioglitazones, because those can exacerbate the macular edema. So jumping straight to the treatment guidelines. So based on the OCT, we have non-center involving and center involving. So how to treat a non-center involving DME? If vision is more than 6/9, you can just observe and follow up. If the vision is less than 6/9, you need to inject with anti-VEGF agents, or plus minus a focal laser. So the rate of progression to a center involving DME is 14% at 1 year, especially in those patients whose diabetes is well controlled. And along with that, you need to get the lipids as well as the BP also controlled if you don't want any sort of progression. So this is an example, 58-year-old male, 6/6 vision, non-center involving DME because the vision was 6/6, was just observed. Here again the vision is 6/6, although the edema is slightly increasing. And once it became center involving DME, the vision dropped to 6/9. He was advised injection, and then following the injection, he's again back to 6/6 vision, and it's remaining stable after that. So you can also do focal or grid laser in such cases. Focal laser targets the microaneurysm which is responsible for the edema, and grid laser helps in reducing overall edema. And you may be surprised that this is a patient who has undergone focal laser, and after a period of almost 8 months, you can see the complete resolution of the hard exudates from the central region. Sometimes you have to be wary when you do an aggressive focal laser. You can have hard exudate migration into the foveal region, and vision can reduce. So center involving DME treatment guidelines, these are what we do day in and day out in our practice. So anti-VEGF injections are the first line of treatment, and they say to inject at least every monthly for a period of 4 to 6 months. You need to inject with anti-VEGF till there is no further improvement in vision, or the anatomy is completely restored. You need to keep injecting till the vision is better. So this is an example, 63-year-old female, 6/12 vision, center involving DME. You can see the small subfoveal detachment there. Give one injection. Again, there is a small detachment. And after the second injection, now you have attained 6/6 vision and also a flat foveal contour, and then the patient is on follow-up. So now what to inject? So nowadays you have multiple choices, aflibercept, ranibizumab, you have biosimilars, you have now Peginex coming out with their FDA approval for DME, and you also have Avastin. I don't know how many of you are still injecting Avastin. So DRCR has studied all these anti-VEGFs, and now what do we know from the DRCR? So we know that anti-VEGF injection with or without macular laser is the most effective treatment, and choosing an anti-VEGF is difficult, but if you give aggressive treatment over a period of 1 year, then the need of injections is reduced. So, and you also need to know many eyes don't respond very well to anti-VEGF, and eyes with good vision with diabetic edema, they can be observed very closely. You don't need to be too aggressive with them and inject. So based on the protocol I won't go to the detail, we know that anti-VEGF therapy with a deferred laser is the current modality of treatment, and you can expect better vision, especially in the group where the vision is slightly lesser than 6/12. So coming to which anti-VEGF which is best, for that we had protocol T, which compared aflibercept, ranibizumab, bevacizumab, and from this we know that aflibercept is same as ranibizumab at 2 years, but better than, and both of them are better than Avastin. So example, 51-year-old male, 6/18 vision, injected 3 doses of aflibercept, vision has come to 6/9, and again one more dose of aflibercept, and then he's stable after that. So which regimen to choose? You have monthly dosing, you have loading dose, and you have treat and extend. Monthly dosing, impractical. Every month patient has to come, keep getting injections. It's a huge economic burden for them. Then you have the loading dose. You give monthly 3 injections every month for 3 months or 6 months. That is what the European guidelines say. And then you reassess the vision and the OCT, and then if you can do a focal laser if that's required. So the main take-home point here is that you aggressively treat DME for the first year, then your need for injections is reduced in the next 2 or 3 years. So that's what you need to tell the patient. Patients who cannot routinely follow up, you can advise the treat and extend regimen, and that has shown to be provide good results similar to the monthly cohort. So now what about non-responders? For them, you need to know why they don't respond. That's because the anti-VEGF is probably it's resistant to them. They may be having an inflammatory component for which you need to treat them with steroids. So what to do in such cases? Switch between anti-VEGFs. You can switch to steroids, or you give a combination of both. You can even do laser, or you need to rule out surgical causes of diabetic edema. Now in such a patient, if you have access to OCT angio, you know there is ischemia, and his vision won't improve following anti-VEGF therapy. So example of switching anti-VEGF, 6/24 vision patient was on ranibizumab, 3 doses, not resolved, given switch to aflibercept. You can see the subfoveal detachment has resolved, and then continued 3 injections of aflibercept, and his vision has improved to 6/12. Now what about steroids? So inflammation is one of the causes of DME, and steroids basically helps in reducing the inflammation, and these are the current indications. So basically the second line agents for treating DME, that is not the first choice in a patient who presents to you with DME. So example of a patient with chronic DME, 6/36 vision, 72-year-old male, given 1 dose of Ozudex, and that's the foveal contour has completely flattened. And this is the same patient with the Ozurdex implant you can see in situ. So it's also helpful to give Ozurdex in these type of patients where you have aggressive PDR with membranes, and then you can avoid anti-VEGF in them and suggest Ozurdex. So what about eyes with DME and good vision? We have protocol V for that, and again the protocol V showed if the vision is good or better than 6/9, you can just observe them, no need to aggressively treat. You can just follow them up, and if the vision is dropping, then you can advise injection. So example of a 65-year-old 6/9 vision patient, had a mild center involving DME, but vision was stable. Given 1 dose of aflibercept, the vision is still remaining at 6/9 and then is just being followed up further. So in the real world, you cannot advise very aggressive injections. Patients don't come. In a year, you can give only 3 or 4 injections because of the existing problems. And in the Indian scenario, the cost is a major deciding factor. You have a lot of options to treat, and you need to tell the patient for a good systemic control, and you need to talk to the patient really and tailor the results for individual patients. So to conclude, you have multiple choices for anti-VEGF. Affordability depends on the patient and the surgeon preference. Protocols can be personalized monthly. Aflibercept is good if vision is better than 20/50, that is better than 6/12. And for those whose vision is better than 6/9, you can observe them. If you give early intensive treatment, then the need for injection reduces in the next years, and focal laser can be considered if there is a non-center involving DME. So you need to start treatment very early, and you need to talk to the patient and identify the barriers, and you need to know there'll always be non-responders. So the future, Paginax has been approved, and you have other multiple drugs in the pipeline for DME. These are my references, and thank you.
I didn't want to stop because the talk was so good, well summarized and concise. Thank you. Next speaker.
Now moving on to talk 2.
Yes, talk 2, yeah.
This basic squint examination demystified by Dr. Samyukta Sadashivan K. She is a trained pediatric ophthalmologist, strabismologist, and a phacosurgeon presently placed in Government Medical College Thrissur as an assistant professor. Currently involved in the academics, research activities, and surgical training of residents in Government Medical College Thrissur. She has many publications and presentations to her account. Welcome, ma'am.
Thanks for that. Good afternoon, everyone. Right time for a squint evaluation, just prior to lunch. I am supposed to do a 7-minute super fast examination as suggested by my dear friend and chairman of the CME, Dr. Divya Kishan. So the goals of a thoroughly performed squint evaluation are to establish a strabismus diagnosis, to diagnose amblyopia, to assess the binocular single vision, and finally to characterize and measure the ocular deviation. So we aim at a focused, time-bound, efficient evaluation to reduce the amount of fatigue to the patient as well as the examiner. So due importance has to be given to the history-taking part, stress on the time of onset, duration, frequency of the deviation, prior history of strabismus surgery or any other periocular surgery, precipitating events, prolonged screen time, etc. All these need to be noted. Probe into the birth history, development history, and do not miss a family history of squinting. And while you take the history, observe the general demeanor of the child, see the family dynamics. So many things run in the family, like blepharophimosis syndrome or albinism, and note the peculiar visual behavior, if any, like roving eye movements, specific facial features, or preferred head postures. And this is followed by comprehensive age-appropriate methods of vision assessment. These are the different tests we have. It is always useful to obtain a FAT scan, familial album tomography scan. See, here the child is maintaining a preferred head posture right from her infancy to the age of 8. All these do matter. Observe the head posture, facial asymmetry, look for proptosis, ptosis, nystagmus, mongoloid, anti-mongoloid slants, rule out pseudo deviations. Now this is a goniometer, a very useful instrument which helps to quantify your anomalous head postures. Important when you operate on a child for anomalous head posture as the surgical indication. You can even make use of a simple protractor and a scale to document these. And now we move ahead with the assessment of extraocular motility pattern. You see the versions first. Any asymmetries there means check the ductions in detail, and a thoroughly performed assessment of ocular rotations will give you an idea about the committance of the deviation. We have these useful apps like this 9-gaze app, where you can make an on-the-spot photographic documentation of the ocular motility pattern. You see the central image first. When you get such a 9-gaze image, you see the central image, note the ocular deviation in primary position, and then you serially follow the other gaze position deviations. And do not forget, you should look for these peculiar movements like upshoots, downshoots, as seen in Brown syndrome and in DRS, and also the coexistent features like globe retraction, narrowing or widening of the palpebral fissure. Now, cross-fixation, which is a frequent accompaniment of congenital esotropia, is frequently mistaken for a sixth nerve palsy. You can actually demonstrate normal abduction in such cases by patching one eye and forcing the child to fixate at a favored target, or you can make use of the doll's head maneuvering. Now, this is how you document the extraocular movements. Grading of underactions and overactions should be followed. And when you check for oblique muscle dysfunction, ensure that the abducting eye is fixing the visual target so that the adducting eye is free to manifest the overactions or underactions. Now you go ahead with the Hirschberg's test. It is required that the patient is able to fixate at the spotlight to get a reliable result. This is a screening test. In a way, it gives you some idea about the amount of deviation. And at this juncture, it is important to distinguish angle kappa from atropia. So what is this angle kappa? It is a monoocular assessment of uniocular fixation to a visual target. The eye would continue to remain deviated with the Hirschberg's test even when you occlude one eye. Now, how do you confirm this? You go for a cover-uncover test, and there would not be any refixation redressal movement on cover test. And remember, this is not a true strabismus. It is not related to the other eye also. You go ahead with the cover test. For all the cover tests, you need a cooperative patient with sufficient vision and central fixation. In manifest deviation, you do a direct cover test. You occlude one eye, observe the movement of the other eye. In 4 years, you do a cover-uncover test. Occlude one eye, see the movement of the eye under cover. You are interrupting fusion, and you observe not only the refixation shift, but also the speed of recovery as well as the control over the deviation. Alternate cover test dissociates binocular fusion, determines the full amount of deviation. Well performed means you will get to know the fixation preference or the ocular dominance. Do not miss a dissociated vertical deviation when you perform an alternate cover test, because much depends on your management protocol by picking up a DVD at the right time. Now, how do you quantify your ocular deviation? You have prism bars and loose prisms to do the quantification. Positioning is of utmost importance. See, the lower prism is presumed to be in the correct frontal plane position, and the upper one is tilted slightly. See the amount of image displacement that it has caused. In large deviations, it is imperative not to stack prisms of the same orientation in front of one eye. However, it is okay to place one vertical prism in front of a horizontal prism in front of one eye. And in large deviations, you can split the prisms between the two eyes and then refer to this Guyton's table, which will give you the total amount of deviation. Remember, 40 plus 40 is 90 here, not 80. Now, this is the method which we resort to calculate the surgical dosage. Prism alternate cover test. You do it for near distance, with and without correction, in the anomalous head posture as well as in the corrected head posture, and in all 9 gaze positions. And one matter of concern here is if the patient is having a spectacle correction with a power equal to or greater than 5 diopters, that spectacle itself will have a built-in prismatic effect. So there you have this option of making the patient wear a contact lens, and then you can perform your prism alternate cover test. In concomitant deviations, it is okay to place the prism in front of either eye, but in concomitant deviations, you should find out the primary and secondary deviations. A and B patterns not to be missed. And in uncooperative patients, you go ahead with the Krimsky test. So this is a prism-added Hirschberg's test. Cyclodeviations in older cooperative children can be subjectively assessed using double Maddox rod. Sensory examination follows. You have the Worth 4-dot test. These are the different interpretations you expect. Bergolini's striated glasses to test BSV suppression. These are the different stereopsis tests we have at our disposal. Stereopsis has to be checked for distance also. Now, cycloplegic refraction is a must in every new strabismic patient who presents to you. Posterior segment examination follows. Rule out fundus pathology like dragged macula. Like in this case, this is a pseudo-exotropia. It is a sequela of ROP. And finally, you will grade your torsions. This is the indirect view of extorsion and intorsion, which is very important in quantitating your vertical deviations. So with that, I conclude. Thank you very much for the opportunity. Thank you.
good talk, and she has demonstrated how to elicit these signs. But I didn't like the way she questioned my Hubli girlfriend, Diya Kishan, for her malady. Yeah. Hubli girlfriend, yeah. Now we'll invite the next speaker.
Next we have Dry Eye Management Newer Perspective by Dr. Sugaranjini, Associate Consultant, Cornea, Refractive and Ocular Services, Giridhara Institute, Kochi. She completed Cornea Fellowship from Giridhara Institute and completed Comprehensive IOL Fellowship from Bangalore Westland Hospital. She is Gold Medalist in Ophthalmology. Welcome, ma'am.
One Jitendra Jatani has designed a prism holder, binocular prism holder. And I think JP would have seen that. The patient himself can hold it in his hand so that examiner's hand will be free. That's a good device for this squint examination. Now we'll go to Sugaranjini for the next talk.
At the outset, I would like to thank Kollam Ophthalmic Society for giving me this opportunity. And dry eye patients are one of the most unhappy patients we meet in our clinical practice. And while dealing with dry eye, it is important to differentiate right at the beginning whether we are dealing with an aqueous deficiency dry eye, that is the deficiency of the aqueous component of the tear film secreted by the lacrimal gland, or with an evaporative dry eye, which is the lack of the lipid tear film secreted by the meibomian glands. And I know you see a lot of these cycles in every dry eye talk, and this puts everyone to a sleep, but these are the 4 pillars that have to be dealt with while treating a dry eye patient. That is the tear film instability and the lack of tear film causing tear hyperosmolarity, which leads to activation of the inflammation cascade, which in turn leads to neural sensitization and glandular secretory dysfunction and apoptosis of the cells. And this is also aided by the extrinsic and intrinsic factor, and a patient must be educated about these extrinsic and intrinsic factors, which cannot be gotten rid of completely. So in a day-to-day practice, we would be probably dealing with more of a evaporative dry eye than an aqueous tear deficiency dry eye. And this is most probably related to the meibomian gland dysfunction. So traditionally what we used to do is a systematic examination of a patient, which would go from a least invasive to a most invasive technique. But and this is probably the only test that was being done previously. This is a Schirmer's test, and this would measure the total tear film secreted, including the basal as well as the reflex secretion. But as we all know, this is grossly inadequate now. Now we have these OCT and ocular keratographs, which give us the exact tear film height, which can be measured, and a 0.22 mm is a normal tear film height, and this can be easily monitored in a follow-up patient. Alternatively, we can use the strip meniscometry, which is more repeatable and more reliable, and this uses the capillary function to measure the tear film volume. Coming to the next pillar which has to be treated is the tear hyperosmolarity, and this can be checked by one test, that is the Fern test. So as we can see from the picture, when the hyperosmolarity is less, as in picture A, you see a good ferning pattern. That is, a drop of tear is dried over a glass slide, and then it's observed under the microscope after 7 to 10 minutes. And if all is good, then it looks like a picture A. Whereas what we see in picture B is that the spaces have increased. C, there are hardly any ferning patterns, and by D, the ferning pattern is completely lost. So this tells us about the biochemical characteristics of the tear film. Now we have something called as the tear osmolarity test, which can be conducted with this osmolarity test pen, and if a value of less than 290 gives us a normal reading, and this gives us a balance among the tear secretion, evaporation, absorption and damage. The third pillar that I was talking about is the inflammation that is induced by dry eye itself, and now we have in-office detection of MMP9 levels, and this gives us a decision on whether we should include steroids and anti-inflammatory agents in our treatment. So this is a very simple test which can be conducted in-office itself, and just like a normal pregnancy test, it gives us 2 lines, a red and a blue if it is positive, and that indicates an inflammation, or a negative test. So the fourth part, which is the meibomian gland dysfunction. Now, as we know, when the lipid layer is lacking, the tears which are produced also evaporate faster and the patient experiences dryness. So what we used to do traditionally is to do a TBUT, that is to check the interval between the last complete blink and the first appearance of a dry spot. But this is affected by various parameters. So what do we have now? We have a non-invasive TBUT, which is given by many of the the keratographs and like the Oculus keratograph. This is an automated capture of placido disc image, which is obtained from anterior ocular surface using a corneal topography system. So how we used to check the meibomian gland dysfunction previously is we used to apply pressure over the central glands, and the secretion of the central 5 or 8 glands used to be assessed for the quality of the mebum secretion as well as the number of glands which are being secreted, and this would be classified further. And but now we have these a MEBO score, that is by using a non-contact infrared mebography, we can actually see the dropout areas as seen in this picture. We can actually calculate the amount of dropout areas in the meibomian glands, and if it is more than 2/3, it is worrisome. All these things can be done by one machine now. These are the new age dry eye analyzers, like such as the LipiView system. So what does this give us? Along with the real-time visualization of the lipid layer, which previously we were actually pressing the meibomian gland to figure out how the lipid layer looks. Now it gives us a real-time visualization of the lipid layer. It also gives us the meibomian gland imaging by the infrared, and additionally it gives us the analysis of the blink dynamics, and I will be telling you why that is important. So it works on the principle of interferometry, and with every blink the lipid layer is distributed across the tear film, and this gives assigning the thickness corresponds to each pixel of the image that is captured, and this is a graph which shows us the increase in the lipid film with every blink. So a good lipid volume would be more than 60 to 75. Also, it gives us a gross count of the partial blinks, and as we know, with every blink the lipid film is like distributed across the eyes, and a partial blink does not really distribute the lipid film clearly. So a partial blink would actually worsen a dry eye symptom for a patient. So as we can see here, unlike in the previous graph, the lipid layer does not really rise with every blink because of a partial blink. And additionally, it gives us a rough idea of the inflammation by even showing us the conjunctival hyperemia and mapping it for us. The fourth point is that we can even use a confocal microscopy to study the morphological and the quantitative analysis of ocular surface microstructures. Like this is the corneal epithelial layer as seen in the normal patient as well compared to a patient with a dry eye, where we can see more hyperreflective characteristics. And also the corneal nerve layer as seen on top of a normal patient, whereas compared to a dry eye patient, the number of nerves is also less. And this is an imaging of the meibomian gland. As seen on the right side, compare the right to the left, there are several changes that can be noted on confocal. So I'm not going into the management using medication, but it is important to understand the etiology before prescribing any topical tear film substitutes to these patients. But the most recent advances are the vector thermal stimulation, thermal pulsation, and the intense pulse light therapy. So vector thermal pulsation, which is known as LipiFlow, many of your patients must be asking us about it. This gives simultaneous application of heat as well as pulsation to the eyelid pressure, but it is not suitable for advanced diseases with widespread meibomian gland loss. And intense pulse light therapy, it helps more in patients with lid margin telangiectasia. So it decreases the inflammation by the thermal effects, and even though it's questionable in patients with increased pigmented population, it is still proven to give a good effect. So it is basically in intense pulse light therapy, it is applied through the skin, and these absorption of waves happen through the blood vessels carried by the oxyhemoglobin and causes a local heat generation and coagulation of the blood vessels, and this reduces the telangiectasia of the lid margin and relieves us of the inflammation. So if a patient asks you which would you choose, which is more ideal for me, you need to understand just the advantages and disadvantages. That a LipiFlow can give you a better relief with a single session, but intense pulse light therapy requires at least 2 to 4 sessions to give optimal results. And topical anesthesia is required in a LipiFlow patient, and the cost of the treatment is also much higher in a LipiFlow therapy. And in case of severe dryness caused by advanced meibomian gland loss, a LipiFlow would not work, and in such a patient, an IPL would be much better for such patient. And in addition to the dry eye effects, it also has an antimicrobial effect, and it also can be used in patients with rosacea. And it is said that in IPL patients, they need artificial tears of a lesser quantity compared to the patients with LipiFlow. And but IPL patient is therapy is contraindicated in patients with who are using photosensitizing drugs, and in such patients, LipiFlow is advisable. In aqueous deficiency dry eye, one must know about the minor salivary gland transplantation, which can be used to aid in increasing the tear secretions. Thank you very much for your patient listening.
I am infatuated by the teardrop microscopy. You have heard of urine microscopy. Like that, teardrop microscopy. It looks to be quite easy to do. You take
make an etiological diagnosis before you start the treatment, or there are some cases where you just prescribe lubricant drops. No, for any, especially post-operative. Post-operative is the time when we usually encounter these sort of things. That is one thing. There are also other people. Any patient who was above 40, 50 years, you see a lot of them coming with these sort of symptoms. So all those things, would you actually go for this sort of an etiological workup, or are there cases where you just prescribe lubricants?
So frankly, in all patients who complain of dryness, we call them back on another day, because we do not examine them after dilatation drops have been put or any AT has been done. So any patient complaining of dryness, we call them back to the dry eye clinic for a workup. And we do not have the dry eye analyzer as yet. But we do a complete evaluation. We even examine the lacrimal gland. Even just with the traditional method of examination, you can classify the patient significantly into whether they're aqueous deficiency or evaporative. And based on that, we decide on the treatment. It's very important to classify the patient, whether it's an aqueous deficiency or a evaporative dry eye. I think that is the most crucial step. You don't need these fancy dry eye analyzers in the clinic on a day-to-day practice. But it is important to give the patient the chair time, because they are quite unhappy, and most of them are happy when you listen to them and give them the right treatment, I feel.
Especially in refractive surgeries, the amount of haze that comes in is directly proportional to many of the ocular inflammation that is pre-existent there. Yes. So now I think Narayana Netrala is coming out with a kit where they measure interleukin 17, ICAMs, MMP 9, so you can have a targeted delivery against each. So especially vitamin D levels. Yeah. So I think more than cataract, I think cataract-refractive surgeries, especially the surface procedures, require a detailed evaluation of the tear film, the meibomian gland function, all those fancy tests you had told about, meibography and lipography. So that's, I think, where the future is heading.
Yeah. We are eagerly waiting for that kit.
I think I got one more presentation, isn't it?
Two more presentations.
Two more. So next is?
Let us move on to next topic. It is tiresome eyes by Dr. Anju V. Chandran. She is currently consultant in orbit and oculoplasty and academics director at Comtrust Eye Hospital, Calicut. Awardee of Professor V. Velayutham Award for Academic Excellence. She is reviewer at Kerala Journal of Ophthalmology and Scientific Committee member, Calicut. She is presented at national and state conferences and has published in peer-reviewed journals. Welcome, ma'am.
Thank you so much. So I hope you all are feeling this, or at least it's a wrong time to ask for. So imagine you're feeling like this in your OPD, and suddenly a patient comes in with this dreaded complaint, and you know what the complaint is? Tiresome tears. So I'll be attempting to give you an overview of this condition. First, let's look at two terms which are used interchangeably. One is hyperlacrimation and the other is true epiphora. So what do you mean by hyperlacrimation? It is basically excessive watering caused due to any irritation to the cornea or the conjunctiva, like dry eye or a misdirected lash and so on. Whereas a true epiphora refers to any obstruction in the lacrimal outflow pathway. Having understood that, we need to take a detailed history of the patient, the duration of symptoms, when it began, whether it is just one eye or both the eyes, whether there's any preceding history of trauma or any ocular surgeries, any history of recent use of drugs that has caused a drug reaction. So coming to the topic epiphora, like I said, it is an anatomical obstruction. So that is just one kind of epiphora. The other is due to functional or non-obstructive cause. Let's look at a few causes of functional or non-obstructive epiphora. The most common condition that leads to this are lid abnormalities, whereby there is a lid laxity such as in entropion, causing an inward rolling of the lids. Ectropion, where there is outward falling out of the lid and the puncta is no longer opposed to the globe, causing watering. And in conditions such as this, where there is incomplete closure of the eyelid, which is known as lagophthalmos, and most commonly associated with seventh nerve palsy, where there's also a lacrimal pump failure. Now look at this child. You can see that there is watering. Obviously, the tear film height is increased, and medially there is a fold of lid. So this is a rarer condition seen in children, which is epiblepharon. And some other conditions that can also be associated with watering in children are congenital ectropion. Looking at anatomical or obstructive epiphora, in order to understand this, we need to have an understanding of the nasolacrimal duct system. So talking briefly about the anatomy, it begins with a puncta, and both in the upper and the lower lid, leading to the canaliculus and then a common canaliculi, which then opens into the lacrimal sac and continues downwards into the inferior meatus as a nasolacrimal duct. So routinely in your OPDs, you must have all performed syringing. So when you do syringing, this is the route that you expect the tears or the fluid to take and reach the nose. This can be done either through the upper canaliculi or the lower canaliculi. So now that you've understood the anatomy, the obstruction can begin at the level of puncta, which could be due to a punctal agenesis, punctal stenosis, or peripunctal lesions. Look at this patient. He was walking around for a year with complaints of watering and discharge, but to no relief with multiple medications. So gently look at his upper lid. You can see a pouting puncta, and on pressure, there was discharge of concretions that were coming out of it. This was a case of canaliculitis. So as you are performing syringing, it's not always that you keep getting free or patent syringing. So let's look at a few variations. One, when you see regurgitation of clear fluid from the same puncta, which would mean a level of obstruction, as you can see. How would you confirm? You do probing, and this would lead to a soft stop, which is diagnostic of a canalicular obstruction. So canalicular obstruction can be just monocanalicular or bicanalicular. It can be proximal or distal depending upon the level of obstruction. Now this is another finding that you would get. This is regurgitation of only clear fluid from the opposite punctum. So obviously the next thing that you would do is do a probing, and here you get a soft stop indicating that there is an obstruction at the level of your common canaliculus. So look at this. This is regurgitation of either clear fluid or mucoid fluid or pus from the opposite puncta. So this means that next you need to do a probing. So on probing here you get a hard stop, which means you do not have obstruction there, or you have obstruction way below. So this is an indicator of primary acquired nasolacrimal duct obstruction, or otherwise known as PANDO. So it presents as an acute presentation such as acute dacrocystitis, or a chronic presentation. Some patients present with lacrimal abscess or the presence of an acquired fistula. Here in most patients you would be able to elicit this technique, this sign, whereby you will see regurgitation of pus on gentle pressure over the lacrimal sac, and this is known as Roplas. So the gold standard for PANDO is to do a dacrocystorhinostomy. This can be done by either an external or endoscopic endonasal approach. I have a short video here. So after doing a preoperative nasal endoscopy and doing nasal packing, after giving local anesthesia, a curvilinear incision is placed around 3 millimeters away from your medial canthus. gentle blunt dissection is done till you identify your medial canthal tendon. After that, you gently scrape and free the periosteum, and which is just then incised. Gently elevate the periosteum of the anterior lacrimal crest and identify the lacrimal fossa. Osteotomy is initiated, and then the ostium is enlarged by using serially bigger sized rongers. Once you've done that, you inflate your sac and you create sac flaps by using H-shaped incisions. After that is done, you identify the nasal mucosa and you will infiltrate it with local anesthesia. An H-shaped incision is then created in the nasal mucosa. The anterior flap is raised and the posterior part of the nasal mucosa is trimmed. And the sac and the flap are then sutured together with the help of 6-0 vicryl sutures, which are then taken continuously as subcutaneous sutures, as I like to do it, to prevent overhanging of the sac flap anastomosis. And then the skin is closed with the help of 6-0 ethylone or any non-absorbable sutures of your choice. This is confirmed with an on-table syringing. So having looked at that, you would have seen children being referred to you with complaints of watering by your pediatricians. So they will give a history of watering, discharge, and matting of lashes. And this is referred to as the congenital nasolacrimal duct obstruction in children. And the pathology is due to an imperforate Hasner's valve. So often you can see that, I'll be done quickly. Often you can see that there will be a bluish swelling in some children. This is because of retaining of amniotic fluid. And this is known as a dacrocystocele. What you need to rule out are intranasal cysts. So management is by doing a Krigler's massage. This is a simple procedure whereby we instruct the parent to do this diligently by giving adequate pressure and starting from just behind the medial canthus all the way down to the side of the ala. It is said to be an effective treatment. In cases where it does not work, then the child is taken for probing under endoscopic guidance. And in cases of failed probing, they go on to do an external or endoscopic TCR. So I just have one question for the audience. You can think about it and come back to me later with an answer. Patient has true epiphora. You do a syringing. Syringing is patent. But on doing Roplas, there is emptying of the fluid into the nose. What is the condition here? Anybody? Yeah, with that, thank you.
Actually, it's a very enjoyable surgery. I have done about, I think it should be more than 100 DCRs. JP would have done still more. I don't know, in RIO.
Our next topic for the session is Basic Workup of a Glaucoma Suspect by Dr. Kiran Gopalakrishnan, currently consultant in glaucoma and anterior segment at Precise Specialty Eye Care. He earned his MD Ophthalmology from RP Center AIMS, where he is graduated with Best Resident Award. He is a regular faculty at instruction courses in KSOS and IOS. Welcome you, sir.
You want to tell something?
Dr. Anju, I just had a doubt. How many times do you ask them for this Krigler's massage per day, generally?
So I routinely instruct the parents to do at least 50 to 100 times a day. So this, I tell them whenever the child is sleeping, that's when the child is most cooperative. So at a time, say you do it 5 times a day, do at least 10 times, a minimum of repetitions. And this has to be done. When we instruct, we tell them to cut the nails because it's gentle baby skin that we'll be dealing with. And also to use either ointment or a little bit of coconut oil so that repeated massage does not cause excoriation.
Thanks to the organizers of the Kollam Ophthalmic Club. I also wish to say that in spite of my grey hair, I will be eligible to present in the YOLK CME for another 3 years. Okay, so this is a basic workup of a glaucoma suspect. So see, a glaucoma suspect is usually a provisional diagnosis that you make after performing a clinical evaluation. Right? You have already performed your 78 or a 90D. I prefer the 78D, and you then classify the patient as a disc suspect or an ONH suspect. Or after performing a gonioscopy, you find that this patient is an angle closure suspect. or after performing Goldman applanation tonometry. Because of consistently elevated IOP, you classify them as an ocular hypertensive or an IOP suspect. So these are the three categories of glaucoma suspect. You have made a provisional diagnosis after your clinical evaluation, and now you start the workup to identify whether this person actually has some early glaucoma or not. So let's start with the first investigation, fundus photo. So if you notice, all the international societies are very clear that this is a strongly recommended test, and the level of evidence to perform this test is also very high. But I am sure most of us do not give a lot of importance to fundus photo. And why is fundus photo so important? There are two reasons. One is for reliable detection of disc hemorrhages. Now, it has been documented that in landmark trials, even in the hands of expert glaucoma practitioners who have no time pressure on examination, they still miss 10 to 20% of disc hemorrhages. You can imagine the number we are going to miss. So fundus photo is one of the best methods to detect disc hemorrhages. But probably more important than that is detection of these wedge-shaped RNFL defects. These are one of the most earliest signs of glaucoma. They are more accentuated on your green reflectance imaging, where the wedge defects becomes a little more contrasty. But the importance of these RNFL defects are that they can appear before development of visual field defects. For example, in this very own patient, if you look at the visual field analysis, and you see just about 2 or 3 depressed points and they are not contiguous, and you would dismiss this field as actually normal if you apply your typical Anderson criteria. But this is an important patient because he has already developed an RNFL defect which you would not have detected if not for the fundus photo. Now, again, well documented in literature that more than 50% of patients in the ocular hypertension treatment study who had a change in the fundus photo did not have a corresponding visual field change at that point of time. So that is why fundus photo is so important. Second is perimetry. Now, I don't have to tell you that it's a strong recommendation, and the level of evidence to perform the perimetry is very, very high. Now, between 24-2 and 30-2, my advice to anybody who is still doing 30-2 is don't do it. 24-2 should be the basic method of examination. I'll tell you the reason why. Because in a 30-2, and you find that in 24-2 we are basically eliminating all the edge points, but keeping only the 2 nasal points which is marked in green there, and that is because it's very important for glaucoma. In a 30-2 printout, you are going to eliminate the edge points as part of interpretation anyway. Then why do you have to do a 30-2? 24-2 is faster, and basically there is no loss of diagnostic information. As far as strategy is concerned, the default choice you can use Sita standard, and the corresponding for octopus would be the dynamic strategy. And for young patients and experienced here refers to people who are experienced in perimetry, you can shift to a Sita faster or fast program depending on the model of perimeter, HFA perimeter that you have, or the top strategy in octopus. 2 things regarding fields. Reproducibility is critical in glaucoma suspects. That is why it is always advised to take at least 2 baseline fields. Let's look at this example. You see a defect on the right eye that looks very much like glaucoma, but on repetition the fields have completely disappeared. So reproducibility is very critical. Do not rely on a single positive field test to make a diagnosis of glaucoma. And the second thing is location and pattern is important, very key, especially to detect subtle defects. Let's look at this example. So if you look at the corrected probability plot, let us zoom in onto the corrected probability plot here, and you can find that, Prithvi, this is a magic move, zoom, you know. Okay. So you see just 2 depressed points at P less than 5%. This does not appear very significant, right? But if you were to take the sensitivity loss in the adjacent points, which is what the octopus perimeter does in what is known as a cluster analysis, you find that that area is marked in red, which is a p-value less than 1%. And lo and behold, if you look at the fundus photograph, you can find that there is a supratemporal RNFL defect, again marked more clearly on the red-free green reflectance image. Again, a field that you would have dismissed as normal. Computer imaging. For practical purposes here we are looking at OCT because HRT and GDX are not routinely available in most centers. Unlike the previous 2 recommendations, the strength of recommendation is very weak by all the international societies to perform OCT, and the level of evidence is low. But there are some advantages. One, OCT can detect changes before your visual field changes if you use it wisely. Let's look at this field, for example. This is almost a completely normal field of the left eye of a patient. But there is a fair amount of cataract. You can see that the fundus image is not that clear, but you can see that infratemporal thinning in the neuroretinal rim. But here you can basically confirm a diagnosis of glaucoma, right? Because when you look at the RNFL, you can find that the Tisnet graph shows the infratemporal dip marked in the red arrow. And you can confirm that with other software features available in your OCT, like the minimum rim width, which is also showing an exact dip in the exact same location. And you can, for completion, even perform a macular ganglion cell analysis that also shows the same infratemporal thinnings. Here there is a confirmation. It is also helpful in those cases of difficult perimetry. There are a lot of patients who will continue to do unreliable fields and who are physically challenged, and you know from the very beginning of your examination that these patients are not going to get you reliable fields. In such cases also it is very useful. Let's look at this example of a glaucoma suspect. I look at the fundus photo, the RNFL patterns are all good. On the first field evaluation there is a defect, but you can see that there is almost 25% false negative errors. So naturally you repeat the fields and the patient has completely gone bonkers. The false negative errors have actually increased. And this happens in some patients, like a reverse learning curve. You repeat the test, the errors are going to increase. But in this patient, now we have an option to do an OCT and confirm that there is no glaucoma. Just like, you already saw it in the fundus photo, you can also reassure the patient that there is no glaucoma. The most important thing, do not base your treatment decisions on OCT alone, because as I already said, the level of evidence is low. Do not base, because OCT can be influenced by so many factors. It's a very sensitive technology. And an example, like even a poor centration like this can cause a false positive OCT. Once you correct the centration, the OCT is normal. I can give you a lot of examples. This is a large disc with a peripapillary atrophy, almost 360 degrees. The OCT is again positive on examination, but when you look at the fundus image, you can see that the disc diameter is about 2.8 millimeters, a large disc, and you can see the peripapillary atrophy. The RNFL patterns are all absolutely normal. And again, the field is also showing normal. Just because you see a red on the clock cover sectors in OCT, do not treat. And finally, pachymetry. Now, pachymetry or CCT, central corneal thickness, the strength of recommendation is weak. It is basically useful for baseline risk profiling, right? And it is the consensus of all societies, including expert panel, which have looked at the EGS guidelines and everybody, that no correction formula should be used, and this habit of corrected IOP should, you should basically avoid it. And again, the CCT importance is primarily for one class of glaucoma suspects, that is the ocular hypertension or the IOP suspects, where we already know, everybody has seen this particular bar chart multiple times, that as the CCT goes on decreasing, the risk of glaucoma goes on increasing. But the same benefit has not been documented in other forms of glaucoma or in glaucoma progression. So it's a list of studies. You can find that some studies show evidence of benefit of CCT and some studies do not show. That is why I say that the evidence is inconsistent. So in other words, in the workup of a glaucoma suspect, you have two strong recommendations to perform fundus photo and perimetry, and weak recommendations as adjuvant tests. You can perform computer imaging like OCT and CCT. Thank you for your kind attention. Welcome. Any questions?
Yeah, thank you, Kiran. Yeah, in the short period of time, I think you have covered most of the basic screening. So this, I was also thinking a lot about this OCT, that OCT is going to make a lot of changes in the way the glaucoma is screened. So based on this level of evidence, so would you recommend this OCT as a mandatory part in the glaucoma screening?
I think, look, the reason why we say that the evidence is low is because almost all the landmark clinical trials, all the glaucoma landmark clinical trials, all of them were conducted in the late 1990s and early 2000s. And none of them were using OCT. So they were looking at the optic disc in two different ways. One is structure, the other is function. Function was always perimetry. And the structure was always to take a fundus photograph, stereo photograph, right? So if I make it a point to say that OCT should be used in glaucoma screening in every patient, I think the problem is OCT is likely to be misused. That is the biggest issue. But if you notice all the recent trials that, for example, there have been no landmark trials for many years. One of the recent trials is the LIGHT trial that compared the SLT versus standard medical management, which was conducted in the UK over 6 years. They were all performing OCTs. So in the recent trials, one of the ways to evaluate structure has been OCT. It's just that if you start treating patients based on OCT findings alone, then that is going to be a problem. But I think a good quality OCT and very good interpretation can be a very, very useful tool. But I can show you a lot of examples. For example, one of my fellow cataract surgeons, there is a, I can actually show you his, his fields are all normal, but one of the OCT RNFL analysis alone shows a temporal inferior TI thinning. But that is not replicated, for example, in the ganglion cell analysis or the minimum rim width. Now, the problem is that a lot of people will look at a single printout of an OCT RNFL. That is usually on the basis of one circle scan, say 3.5 mm circle scan, and find this red and immediately start patients on treatment. So I feel OCT is an extremely useful tool, but you should be really good at, first of all, the OCT quality has to be really good. I mean, I have no financial interest here, but some OCTs are actually better than the others. That is a fact. And the fact that you should be able to visualize your OCT on your own computer screen so that you can see multiple circle scans, you can see, the minimum rim width and a lot of things, and then you corroborate it with what you find.
In that particular case that you were mentioning about your friend, where your field and the other thing did not actually
corroborate. So I am not treating him.
You are not treating him?
No, that is the point. The point is, but it is still very useful, because the next time, after a year later, I am doing a fundus photo, I am looking at the optic disc, and that area I will be looking at very, very closely.
So if you detect a progression in OCT alone?
If it is not corroborating, I will just show you an example. Can you still show it there?
How old is that patient? Over 70, 75?
He is a fellow cataract surgeon. He is hardly 30, in the 30s.
Oh, and is he having that defect? Yeah.
He has a family.
So I think above 70 years, I think you can ignore that, because small defects, arteriosclerosis is localized ischemia.
Dr.
like
Sai
that.
has probably left in CME in Thrissur. Dr. Sai was saying that there was one patient who had an OCT which was marked initially as yellow. And after 6 months, when they looked at the OCT, it was marked as red. And now the doctor apparently told him that 50% of your nerves are gone and you are in trouble. And when the patient came to Dr. Sai, the fields, everything was normal, and the patient basically did not require any treatment. So that is the problem with OCT. It's a very sensitive technology, but the fact of the matter is...
But Prashant, the Bavankule, he is giving a lot of importance to this OCT.
Yeah, I'll just show you a simple example of how an OCT can actually be troublesome. But I could not put in a lot of these slides. So this is a patient from Maldives. Okay. So let me see. Oh, I can't find it. I'm sorry.
Okay. Yeah, I think maybe...
Dr. Kiran, I just had a doubt. I'm in a unique position where getting a visual fields is difficult because of shaft shortage.
Okay.
Whereas OCT is easily available. I can get it done in in half a minute. Many a times I've noticed, and of course it has been described, the pattern of ganglion cell loss is superior temporal, inferior temporal, mainly inferior temporal.
Yes.
And we get many other different patterns of ganglion cell loss also. And I have been recently, Dr. Manjusha has been showing me, I have been getting vertical cutoffs in the ganglion cell loss also.
Yeah.
I was thinking...
I'll show you this example, for example. So this is the left eye of a patient from Maldives. So he came in 2022. The right eye has definite glaucoma, there is no question. So as part of the routine workup, an OCT was done on the left eye also. And this is the finding, right? Okay, and you see that in the nasal area there is a dip in the Tisnet graph. This does not really correspond to glaucoma. You don't expect a temporal or a nasal thinning. It doesn't correspond to the typical path of the retinal nerve fiber bundles. So a pattern like this, my importance of saying this was, he came just last month for his 1-year follow-up, and see what happened on the OCT. Now that has become red. Okay. Now I dismissed it because the patient's fields are absolutely normal in the left eye. But the problem is the patient is telling me, look sir, it has become red. Now the issue is here there is a clear problem. You can notice the arrow there. There is a poor segmentation there in that area. The red line has dipped because the ILM has been poorly segmented. And therefore, I could actually retest and tell the patient that that is because of a poorly done test. Once you retest, everything is normal. But this is a problem that even doctors, when you see this yellow becoming red, immediately thinks, that is why I said OCT, very sensitive. But unless, for example, if you did not look at the B-scan graph there, and if you did not identify the abnormal segmentation, you will also think that this is a problem. That is why it is important for all the tests to corroborate. If all the tests do not corroborate, it doesn't matter.
Practically, are there any examples where you can tell us that the OCT has helped you specifically, for example, when you roll out the other things, in addition to the other things, OCT has specifically helped you in diagnosing and treating a case?
Yeah, that is helpful in certain specific situations. For example, I'll show you this example, I think.
Who taught this patient that yellow to red is happening there? The patient is a doctor. I see.
So again, look at this fields, right? There is a defect, but it's very advanced. It looks like a very advanced defect, but there's a fair amount of false negative errors at 25%. Here, how can you be 100% sure that these defects are because of glaucoma or because of the false negative errors? Because even on repeated testing, I could never get below 25% false negative errors. But here, again, the fundus photo is very helpful, because the fundus photo clearly, can you remove that speaker overlay? The fundus photo is actually showing an early wedge-shaped defect there. And now here the OCT is helpful, because if you perform the OCT, you can actually exactly in that area where you find the RNFL defect, you can actually find the supratemporal thinning. And now you can be 100% sure this is glaucoma. And because you have able to get a good quality OCT, it can be useful for progression also, progression analysis later, because he is not going to do good fields. This is quite an old patient, in the 80s. So there are those situations where OCT is really helpful. So when you have unreliable fields, for example, and you want to diagnose glaucoma, but again, see, everything is correlating. The fields may be unreliable, but the fundus photo is correlating, the OCT is correlating to the exact T. So that is the most important thing, that all the tests have to correlate. On an isolated, a single test, you cannot actually do this. That is the most important point, because you cannot treat anybody on the basis of a positive OCT alone.
Dr. Kiran, now we have neurological conditions like Alzheimer's, Parkinson's, where you have these similar supratemporal errors. So can we have any clue as to, is it glaucoma or?
If in doubt that the patient is glaucomatous, don't treat, observe. The natural progression of glaucoma in most circumstances is very, very slow. It is a false conception that the moment you see a visual field defect or some positive change, you immediately start treatment. If you go back to the landmark trials, for example, the early manifest glaucoma treatment trial, where early glaucoma patients were classified into either for treatment or for observation. Even in early manifest glaucoma, 35% of patients who were diagnosed with glaucoma did not progress for 7 years without treatment. So if you are at any point doubtful whether the patient has glaucoma or not, don't treat. Just observe, because over a period of time, if it is glaucoma, he is likely to progress, and then you can obviously treat him.
Strangely, we had a lot of discussion in the last talk, in spite of being hungry, but it was interesting. So we wind up the scientific session of the day.
Thank you so much.
Good luck to everyone for a good educational experience.
Thank you from all of us here to the Kollam Ophthalmic Club and the organizers, the young people. Thank you so much, even though we find ourselves on the wrong side of that line that you have drawn.
Thank you.
Thank you so much, sir. Now, may I request Dr. Venugopal, sir, to hand over our token of appreciation to Dr. K. Mahadevan, sir. Dr. Biju Jonsi. Dr. Edwin James. Dr. Shishir Verghese. Dr. Samyukta Sadashivan. Dr. Sugaranjini. Dr. Anju V. Chandran. Dr. Kiran Gopalakrishnan.
So we happily wind up the YOLK Inside CME. We would like to thank you all from the bottom of our heart for blessing us with your presence. Please enjoy the lunch and have a good day. I request all the KOA members onto the stage. We'll take a photo.